Good afternoon, everyone. We'll maybe get started. Welcome to the session on data and data quality. My name is Kathy O'Reilly. I'm the Vice President of Quality and Performance Improvement with Extendicare Canada. So it's my pleasure to welcome you all here this afternoon, as well as it's a pleasure to be able to introduce our three presenters for this afternoon. So just to provide you a little bit of an introduction to each of our speakers. First of all, I'd like to introduce Natalie Damiano, and I always practice their names before I start. Natalie is the Manager of Home and Continuing Care Data Management at CIHI. Natalie is responsible for the management of CIHI's clinical data standards, education and support relating to continuing care and home care reporting systems. She's also for overseeing all analysis and reporting related to HCC and for engaging external stakeholders with interest in HCC reporting systems. Prior to coming to CIHI in 2003, Natalie worked in a rehabilitation and continuing care sector for several years as a clinical physiotherapist, educator, and researcher. She continues to be a registered physiotherapist and is active in the physiotherapy professional community. So welcome, Natalie. Our second presenter, and I'm thinking that some people will be presenting together. Sorry, we'll go through all of you at once. And where did you? I got a late handwritten overview here. I'd like to introduce to you as well Stacey Calamecco. Stacey is the Manager of Data Quality at the Ministry of Health and Long-Term Care. Stacey's team is responsible for data quality across the healthcare system, specifically focusing on data elements used in funding methodology. Stacey has extensive background in acute care, specifically related to health information management. And our last presenter is Patricia Pat Norrell. Pat began her career in long-term care in 1979 as a director of care in a 20-bed facility in southwestern Ontario and remains as passionate today about the quality of care and life for residents in long-term care as she was then. Over the span of her 32 years in long-term care, Pat has been a director of care in both small and large homes, private and municipal, an administrator and a resident care consultant with an organization that owns 17 long-term care facilities in Ontario. In her current role as long-term care consultant with Extendicare Canada, Pat works directly with 5 of the Extendicare homes in southwestern Ontario to assist those homes in meeting Extendicare mission of helping people live better. Pat believes there is no greater calling in life than to be part of the challenging and exciting world of long-term care today. Thank you very much, ladies, and I'll turn it over to you.
Thank you. So Stacey and I, and actually Don Hurdes, were asked to put together between us some information on our role in data quality and what we think of as a shared responsibility. So I'm here to talk to you primarily about CIHI's role. I'm going to tease a little bit in about some of the things going on in research towards the end, and that's in part because Don Hurdes actually is presenting in another session at the same time. So what do we do at CIHI in terms of our shared responsibility? Well, first, just to give a little bit of context, when I'm talking about the kinds of data we have at CIHI, I'm speaking specifically in this room to the Continuing Care Reporting System, or CCRS. So I want to tell you a little bit about that or remind people a little bit. Right now, we get submissions from about 1,200 facilities from 7 provinces and 1 territory. Those include both the complex continuing care beds, which are almost all in Ontario, and then residential care facilities, so long-term care, nursing homes, personal care homes. Every province likes to call them something a little bit different, just for fun for us. We do use as the data standard, as most people in this room are going to be well aware, the RIMDS 2.0. And that, as you know, then gets us to get assessments at admission and thereafter. So thinking about data quality, we're thinking about a lot of different pieces, not just the data as it comes in one at a time, but also the longitudinal nature of it, and if you start to think about longitudinal inconsistencies and things like that. To give you a sense of size in our database, we now have about 2.5 million assessments since 1996, with about 650,000 unique residents from across the country. I think the thing that we all want to always be talking about is that everybody who touches the data, and I'm going to just speak to this a little bit more, has impact on data quality. So we always use words like data, but in reality, the data in our systems is a clinical assessment. So it's assessment information from a resident. So our care staff are the first people who have an impact on data quality and on information quality. And I think that's the other piece that maybe is really important to get at, because data sounds like sort of just a number that you put somewhere. Information drives what we're going to do in practice and how we might think about decision making and where we're going to go from there. And so we often try and think about taking those numbers and turning them into information that means something to everybody who's providing that information into us, because that is really what's happening in the sector. So at CIHI, we actually do have a data quality framework that we've had in place for some time that applies to all of our different databases. So for people who are less familiar with CIHI, we manage about 28 databases that include things like acute care, inpatient rehabilitation, inpatient mental health, home care, continuing care, as well as things like our MIS standards, cost information, financial data, health workforce data, pharmaceutical data, a whole bunch of different things. When we think of all of those different databases, this framework applies. So there's 5 dimensions, and I'm going to speak to some of them as we go through. Accuracy really is probably the biggest one that means something to everybody, because it's really, does the information we get reflect what really happened? Is it, and in this case, is it an accurate assessment of that resident? Timeliness really gets a lot at, is the information available to whoever is using that information in a timely manner to make their decisions? So for example, if your frontline staff are using that information for care planning and for monitoring care, they need to get the outputs of it immediately. If you're using it to look at quality improvement, that might be a little bit different, a timeline. So we look at that concept in timeliness. Comparability really means when you think of both over time and space, can we compare the information? So one of our things we always have to think about with comparability is we've had new implementations come on. So the data changes over time because of that. Usability really gets at, can people access it, and is it understandable? Does it make sense to people? And again, relevance is probably a really critical one, which is really, does it meet both your current requirements but also what you might need in the future? Is it relevant to you? Do you care about this information at the end of the day? We have a cycle that we use when we think about data quality, and I'm going to take us through this cycle and give examples. So there's 3 big parts. There's prevention, which really means, can we get the data, and that really gets to the accuracy piece. Can we ensure that the data comes in accurately to begin with? And that has a number of different factors involved, and I'll go through those in just a second. Then there's monitoring. What do we put back out there for you to monitor your information? And also feedback, which is really getting into analysis using the information, and then how does it close the loop or complete the cycle? So when we think of prevention, the things that we're responsible for at CIHI, or have a shared responsibility for, is we set the clinical data standard and the data standard for the continuing care reporting system. So that means we need to put out the supporting documentation with that, manuals, specifications, all that kind of stuff. We also put together a full training curriculum. We also provide opportunities for client support, and we think about system edits. So a few examples from that. We do put, as I said, a full training curriculum, and I just want to highlight a couple of pieces. The 2 pieces that really stand out are collecting the information. So this is really ensuring that our nurses and other care staff are able to accurately assess the person. So these are the things on how to code using the RAI. The other piece that's really important, because to me, the most important piece on data quality is using the information. And that's how we all maintain and improve our data quality. So we really try, and you'll see it's the longest line here, is on how to use the information. So that goes from using the CAPS and the outcome scales clinically to using the quality indicators and your case mix information and everything else to make organizational decisions. And then just point one last thing. For over the years, we've had a quality series that we've always put on that's very popular in terms of putting out new research or something new that's going on. We've now just rebranded that, called In Focus with Home and Continuing Care. So you'll see that come out as new information. Other things that we do that I think are really important and we've heard really help is we've tried to provide more job aids to help support those quality assessments. And so I have a couple of assessment examples here, some of which people will be very familiar with around special rehab, the therapies, and nursing rehabilitation. And the other piece that we really tried to add into our training, because you take the training, you need to go away and you need to think about performance. And so we've tried to come up with a number of different critical thinking sort of mnemonics that help different people. So this one here, RIE code, helps the people who are doing the assessments. The next one, RIE decisions, helps people who are making decisions. So it helps to take them through some of the questions. And in a lot of our sessions, and when we have booths and stuff, we have little cards for all of these different ones. And the last one is speaking to really thinking about how to submit your data. So what are the steps that you have to take when you're actually sending your data to CIHI? So we've tried to put together a number of different supporting documents that help people with that. Then I'm going to get into monitoring. So the big things we do in monitoring is we put out a number of reports that help you look at your own data and look at how accurate does it reflect what you thought you were putting into the system. So that goes from when you send your data to us, and just before the session started, I had a question about this. When you send your data to us, you get a report that tells you how many records came in, were they accepted, rejected, and some other pieces. You also have an ability to make those corrections over the web. And then I'm going to speak to a few of the other data quality analyses that we do as we go through. So just as an example, this is what the submission reports look like these days. So you will get, there's a front page that talks more about the number of errors and things like that. Most people in this room cannot see this slide. I'm well aware of this. And I won't even just say the people at the back of the room, because if I'm sitting in the front, I still can't see it. But it's just really to give an example, because one thing that comes to mind for me is if you're not used to these and this is a role that you play in an organization, you should ask about why you don't know about these. Because we had things come up this summer where people didn't know they got submission reports and had been submitting for a number of years. And I'm not saying specifically Ontario, but it's an interesting question. So on this one, the one piece that I wanted to tie onto this, because these used to be in different reports, there's a number of clinical checks that we include, some of which are for sure, like if someone's comatose, you can't have certain things. So those are called hard edits, or you actually get rejected. We then also have a new system called Accept with Flag. These replace most of the data quality audit reports. These are the times where there's clinical things that are happening that are really unlikely. So for example, this one's not listed here, but one of the examples I like to give is in the eating part in G1. If you say that someone did not eat, that means they received no nutrition and no hydration for 7 days by any means. Probably unlikely in most cases, so we flag it. And we flag a few others, and this is one area that I'll have mentioned in the next steps as an area we're looking at continuing to make improvement for. So things like if someone is bedfast all or most of the time, have you indicated that they have a turning or positioning program in place? So things like that to get at clinical best practice. We also put out a report as part of a number of databases at CIHI and Statistics Canada for the provincial deputy ministers. It's called the Data Quality Report for Deputy Ministers. And it really is a high-level picture of the quality of the data, and it flags potential issues, and it also provides a trending report for them. And they get it in terms of, they get one table that shows how they compare with other provinces, and then more information on their own province. So for this, I've just highlighted a sense of what it looks like, but if you remember back to those, the framework, accuracy, those kinds of things, we highlight a number of those things. So the number one thing is Ontario actually performs very well on this data quality report. In long-term care, you get a yellow flag, which is not a big deal, and it's yellow really because there's a couple of things that still in the first, it's only been a few years now since implementation, 5.2% of records are rejected because of hard edits. So it's flagging that that's causing more work for people. So, and risking that those 5.2% don't come back in either. So there is that issue. And then the other one here that shows red at the bottom, so we color code all of them, is there's still a few challenges around things like invalid, missing, or inconsistent sex and date of birth between assessments. So that flags. And it's 1.3%, which is a fairly low number, but given the volume of information in Ontario, it's a reasonable number of assessments. But you'll see most of the other things, and some of the things we talk about, went the wrong way. Ontario's data is very complete because mentally there's a mandate for it, so that does make that a little bit easier. But we get all of the data that we're expecting. You don't have very many assumed discharges. This is really good, 0.2%. Again, still that's not a completely insignificant number because of the volume, but overall, what that means is we haven't had anything, for someone's been in the system and we haven't had a discharge, or we haven't had anything else in some time. So that is showing that that's in fairly good shape. So this kind of report goes out to the deputy ministers, and I have seen when I worked in another database for a different province that when they got this, their big thing was, how come we're not in this database? Don't we have rehab beds in this case? And they then joined. So that's kind of part of our purpose. The other thing we do is a few different analyses. So we put out external documentation with our databases every year. So the 11-12 documentation is on the website. It looks at a number of these concepts, and I'll just give you a highlight of what it shows in just a minute. We also support a number of ministry initiatives, including the surveillance and monitoring reports, and Stacey will be speaking to those. And we support different research initiatives, and so some of those are based on work the ministry might be doing or research. So this is really what we wanted to highlight around John Hurdy's work, is that he has done an analysis using a lot of the Canadian data on the overall picture for continuing care reporting system, which, as I'll identify through our external analysis as well, is in really good shape. But the thing that's nice about this is this has just been published. It should be on its BMC, I would say, by the end of the week or so. So I don't have a link for you, but if you look for Hurdy's and look for BMC, that's the open access journal, so it's easy to get and moves fairly quickly. But I think that piece people will really like to have on hand, because I think we all like to have published pieces we can make reference to. So in terms of when we did our analysis in 11-12, what did we find? Overall, the data quality is good. So the Ontario data, the data across the country. Data is very complete. The validity and consistency measures remain high. So what do I mean by that? When the NRI was designed and was developed, the initial research on it that looked at reliability and validity found it all to be very good. And a couple of pieces, an example I'll give you. If you look at the ADLs, ADLs should be measuring everything within what's called a construct when you think about validity. They're measuring things that are kind of similar. So as you become disabled in certain things, there should be a likely pattern to how that will happen. And you can measure that through something called internal consistency. So we continue to do that analysis on the Canadian data now that it's not research data, and the values remain very high for things like the activities of daily living, cognitive performance scale, depression rating, those kinds of things. So it means we can trust the data. We can trust that what we look at really does relate to who the person was. One piece we did notice, and this is so when we think of activity, daily living, and continence, you score what they're rated at, and then somewhere else in the assessment you mark off whether or not you think there's been a significant change. So based on what you've scored, we're under detecting those changes. So for example, someone might change by more than 2 numbers on activities of daily living on any one element, but no one has marked that they found there's been a change in ADL. So that's what I mean by this. So it doesn't mean we're not scoring or coding the ADLs correctly, but maybe we're missing. And that's important when we think about reassessment. So for the clinicians who are doing reassessment, are they missing that someone has changed? Because when we think of long-term care homes, there can be that gradual decline that it's easy to miss some of those little pieces. And that's important because that's really important for care planning. I spoke a little bit before about assumed discharges. And the other one that goes along with this is based on the fact that you're supposed to have a full assessment once a year, about 0.5% of episodes, and these numbers are specific to Ontario, have missing full assessments. So that can have some impacts in a few places because a number of the data elements they're imputed forward from the full assessments, which means after a year that's no longer happening, and then certain scales would not be able to be done properly. And Stacey, I think, will speak to this, and this has been spoken to a fair amount already, but the special rehab has definitely come down, but at the end of 11-12, it would still remain just under 20%, which was considerably higher than historically and across the country. So the last piece, and I need to change this slide so that data analysis and use goes up here, because I think it really fits into feedback. And I just want to speak to me, the most powerful driver of data quality is using and sharing your data. And I've always purposely included that I'm a clinician, and I've worked in continuing care, and I've worked in rehabilitation. And I'll give an example from that. When I used to work in rehabilitation, we had to do the FIM instruments. We used a different clinical assessment. And what we tended to find was the only time we ever got any feedback on that was when we didn't do it. We got the report that said, here's the people who didn't fill in their stuff, right? So you knew you had the list that went up, so you knew who wasn't doing anything. That was usually pretty good, but that's what, and we gave that feedback to our managers, and that changed things, at least in our small program, because what they started to do was start to bring back that aggregate program level information to us to say, this is what your patients look like, your clients look like. Is this true? Does this make sense to you? Does this relate to what you're doing? Should we be using this in different ways? And it really helped to improve that cycle, because if your information just goes into a black hole, it's pretty easy to stop paying attention to what you're doing with it. And I guess specific to the RAI, I would really drive this beyond clinical decision making, because we are using it for clinical decision making, right? You have to do your care planning based on your RAPs. That's built into the system in Ontario. But I do think that the clinical care staff need to know or have some sense of how else it's being used. So when we think about the quality indicators, in particular quality indicators, and I'll stop there for that. Why? Well, I think everybody appreciates the value, understands what's happening with their information. The other piece is that those summary measures, those analysis, really help to spot that suspicious data. Because when you look at that high level, if you just look at Mr. Jones, you might not pick it up. But when you pick up your whole facility and go, I don't think that's right, then that's one of the first things you're going to start to do with a quality indicator that doesn't look right is double check that you've actually been capturing everything correctly. So, a couple of examples on what we try and do to get the data out there. We put an analysis and brief out in November that looked at alternate level of care. So what it looked at was people who were discharged from acute care and went to either home care or long-term care. And we looked at, of those who had ALC days, could we look at information from the RAI assessments that might predict the people who waited in the hospital? And we could. There were a number of factors. The clinical factors predicted waiting a lot better in home care than in long-term care, which is an interesting and not different than other analysis that's out there. So something else is going on when people are waiting to go to long-term care. It's not as simple as their clinical condition is causing them to wait, with two exceptions to the groups. And this isn't going to be a shock to anybody in this room. People waiting for palliative care and people waiting who had challenging behaviors and behaviors associated with dementia. So people who are probably waiting for a specialized care unit are much more likely to wait when they're going to long-term care. So this is available on our website, and people can read the details of it. And then the most recent one we put out at the very end of January, which is our first public release and information on the quality indicators. So the new risk-adjusted quality indicators. And it's called When a Nursing Home is a Home, How do Canadian Nursing Homes Measure Up on Quality? So it looked at a subset of 8 of the quality indicators, and it gave provincial information, and I'll show you 2 examples. And what we also did was, for each of the sort of 4 domains that we focused on, we provided an example of a long-term care home through looking at their data and then calling them up and asking and getting their permission to do everything, had shown quite a bit of improvement in the last 4 or 5 years on that specific quality indicator. What did this report find? No province and no facility is good at everything. But there are people who are doing really well, and therefore are likely groups, facilities, or provinces who we could be asking questions about. What are they doing? Are there programs that have been put in place that can help with some of this? And we also put out quick stats that give that provincial information. So these are publicly available on CIHI's website of 19 of the quality indicators. And the reason we didn't do all 24, for people who look at their reports regularly, that whole list of ADL ones, no one's sure which one to pick. We only picked one of each of the improvement and worsening is one way that we went down, because it does get confusing there. So 2 examples. This looks at people whose behavior symptoms worsened in 11-12. So to orient you, this is the percentage of people. For this indicator, a low number is good, so you want to be down here. These are the provinces: BC, Manitoba, which is just Winnipeg, Ontario, Nova Scotia, which is not all of their homes, but they have implemented for a long time. Newfoundland, not all of their homes, but they also mid-implementation. And Yukon, which is all of their homes, because there's only 3, we can't show their variation. It's their median facility rate. So that means if you lined all their facilities up from the lowest rate to the highest rate, pick the one in the middle. And this is the 10th percentile, which means only 10% of homes are lower than that. And the 90th percentile, which means 10% of homes are higher than that. So what does this one? This is the unadjusted national rate. So the unadjusted national rate is about 12.5%. These are all adjusted rates. So remember, the quality indicators adjust for some of the different risks in order to be able to do this, in order to look at comparing apples to apples. So in this one, the Ontario facility, and you'll see I was strategic on this, the facility median is a little higher than the national rate and higher than the rest of the provinces. But who are these guys? And what are they doing? Because remember, these have been adjusted based on your characteristics of your facility. So if you go into your e-reports, you can find out who these people are, and you can call them. Find out what they're doing and see if there's something that you can learn from it. And similarly, what's Manitoba doing? And Manitoba and Winnipeg, they have had some very specific efforts in this area. Because they do show, as our old vice president used to tell me, what you want is not just low numbers, but the bars need to be close together. Because if you're premier for Ontario, you want good care for every citizen, which means a small variation and a low number. Next one. This is looking at people who maintained or improved their independence, and I spelled this out in a way most people can understand, which is their transfers, their walking, or their wheeling. So this is what we call it's the mid-loss ADLs, but it's the transfers, walking, and wheeling. In this one, a high number is good. So you want to be up, okay? This is a little confusing with the QIs. So on average across the country, it's about 30%. Ontario is above average. And again, who are these guys? Who are at about almost 45%. And above average and really doing as well or just about as well as all the other provinces. And I will highlight here for Newfoundland that again, we don't have all their data, and we don't, because of one of the facilities in here, we don't necessarily think it's representative, because one of the big facilities that has a little bit different a population is in there. So we're always a little bit careful with Newfoundland, and that's why they always have huge variations. So in this case, Ontario looks a little different than it did on the last one, but again, showing something that we can look at. And I think this one really highlights, because of some of the discussions we've been having about nursing, restorative care, rehabilitation, special rehab, I wanted to highlight this because overall, there are a lot of people who are getting a number of residents to maintain independence or improve. So that's good. So where are we heading? Well, we're supporting the ministry in their data quality monitoring initiative. CIHI produces a number of the reports that the ministry then shares. So those most recent ones I think you call surveillance, right? We're also reviewing those clinical quality checks that I talked to you about because there's a few of them that trigger really easily, and we've heard that from clients. So we want to look at, do they really make sense to have on there? Because if you have stuff that shows up too often, people just start ignoring everything. So that's not what we want. We continue to make data available. So we do data requests. If people want any they want their own data back in a slightly different way, you can come and talk to us. If you want custom reports done, anything like that, we can talk about that. When we start to get into custom stuff, we do charge for that, just as a buyer beware. But in terms of returning data, we do that. That is no charge for any of our facilities. And the other piece that we're really involved in is trying to look at how to build capacity across the system, so from clinicians to program managers to health system managers to policymakers on how to use this data at all levels to support decision making. So with that, my key messages really are that the data is good overall for the CCRS data. The international studies and Canadian studies continue to show that. There's the things that are in place, like the edit checks, work, and the rates where they do show up are declining over time. We have lots of training and support available, and really using the data completes that circle. That's all I have. So I'm going to turn it over to Stacey.
Good afternoon. Wow, the room's really filled up. Filled with people who are so excited to be here about data quality, right? Right? Good. Okay, so before I get started, while I was listening to Natalie's presentation, which I always love listening to CIHI because they are a major partner of a lot of what we do in Ontario and all of our data holdings, I just really wanted to illustrate for folks in the audience what the difference is, because a lot of people say, well, there's education here, and there's reports here, and then there's some here, and which ones do we look at? So it's important to note that when CIHI is putting out a specific product report, they're looking at all of Canada. So they are pan-Canadian. That's their mandate. When we, the ministry, look at specific things, we're looking at things that are occurring in Ontario specifically. We still work in partnership with CIHI, and we'll talk really specifically about how we've been doing that of late. But it's really important to note that's the difference, and that's why sometimes you have to go to a couple different places to get the information that you might be looking for. Okay, so hopefully that clears the air a little bit about that. So while CIHI is always doing fantastic work, it's across Canada, and while the Ministry of Health is doing very specific things to affect things provincially according to our needs and mandates. Okay? So I'm going to go over a few things today. So first off, if you're here to talk about your CMI or funding, out of scope. Just wanted to make sure that's clear because I know that's heavy on a lot of folks' minds today. I really want to... You're raising your hand. Yeah? We can definitely talk about specifics about data. Happy to do that. But if you have questions about your CMI or you want to dispute the way the model is working, I don't want to have that conversation today, okay? So that was just my scope conversation. So really what I'm going to go over today quickly is really just paint a picture of the data holdings in Ontario as far as long-term care go. And I probably missed some because while we work very broadly in Ontario, there's sometimes hidden gems that we're not all well aware of. Give you a bit of background, and by background I mean, yes, special rehab. We're going to talk very quickly about it. I'm going to really focus on the positives here, not necessarily dwell on the issue or the ramifications of that issue right now. Really want to look at the positives. What's coming out of discovering a data quality issue, and what are we going to do about it? And I say we, not we. Okay, and data quality initiatives underway, and that's really the key focus of this. That's what I really want to talk about. So the data holdings that I'm well aware of, that you're all well aware of for sure, is RIMDS, and that's where I'm going to focus a lot of my conversation today. But we also have the IQS, which is the Inspector's Quality Solution. So a good number of data that's coming in and being housed in that solution. Facility Management Information System, so the FIMIS, and that's really licensees, bed numbers, those kinds of things. LTC, Healthcare Reporting System, so the MIS, the financial numbers that are coming in from your facilities, so cost per patient, or pardon me if I say patient, I'm going to try to say resident. I fumble a little bit once in a while. And talking about client profiles and CPRO, so that's really talking about the patients who are waiting for placement. Okay? But like I said, we're really going to focus on RIMDS. So background, this is a famous diagram, really made famous by John Hurdy's way back when. So many of you probably remember the teleconference where John started to bring about the harsh realization that there was something happening in Ontario that was very different from anything we've seen before, and we needed to pay attention. So I can remember sitting in my office listening to that teleconference, and I just sat there with my mouth open thinking, wow, what are we going to do? So really what I want to talk about is what are we doing and what do we need to be doing as we're moving forward? And that's really a challenge for everyone to think about, not necessarily just the ministry or CIHI or Inter-RI. It's all of us together because this is our data. This represents each and every one of your homes. So that's really one of the things that I want to spend a lot of time talking about over the next year, is taking some accountability in the data that's being reported and it being representative of the care being delivered in your facility. So what did we do when we had that aha moment and we saw John's brilliant slide that made us all a little skeptical? Scared. I was scared. So we did an initial pilot of 5 long-term care homes in Ontario, and how we got to those homes were we sit at a technical working group with many decision makers that work in the long-term care sector, and they volunteered their homes. They said, come into our homes and do an initial review and let's see what happens. So from that pilot audit, and we did a very small sampling from that audit, we saw linkages to measurable objectives and interventions in the plan of care being missing in a lot of detail. Not a lot of evidence of periodic reevaluations as required, and lack of documentation to support the nursing rehab restorative care. So at that point, we said, what are we going to do now? We felt that there was essentially a lack of consistent education because all of the folks that we talked to in the homes said the same thing. We didn't know. We weren't aware of that. So we said right off the bat, what we have to do is some mandatory education sessions with the homes. So if you recall, many of you probably attended these sessions. In March 2011, we had several sessions between the Ministry of Health, Inter-RI, and CIHI. We hosted these sessions, and we had an overwhelming response of attendance of around 93% provincially, which is great, considering we have 634 homes reporting, which is enormous. What else did we need to do? Well, we know we needed to do some more monitoring and analysis at that point. So we did some of that. And we also knew we needed to do a larger sample. So we needed to look at more homes and more residents. So that then ensued the 25 home data quality inspection that really focused on the assessments that were going to the special rehab RUGs category. So that was the focus. That's what we looked at. High-level results. So we did 25 homes, like I said. It took us from January until July to get through the inspections. We went to 25 homes. We looked at 265 individual residents. We looked at assessments from 2010-11, but then we also looked at concurrent assessments because we wanted to see if there was any change. So we looked at 695 assessments from 2010-11, and why did we do that? Well, if you remember that the curve, where it really started to increase, that's where it started to increase. So we really wanted to know what was happening to make that change, and we also wanted to see if there was anything that changed concurrently. So we looked at 228 concurrent assessments, and according to the criteria that was developed, 0 homes passed the audits when we looked at the assessments for 2010-11, and 1 assessment passed for the concurrent review. Now, a lot of people did not like the process. Completely agree, but what we can say is we knew the results were not going to be good because we picked homes that we knew are at the high end of the scale, that we knew potentially had issues in the way they were reporting that made them different from the rest of the province. Okay, so we can argue the point about the inspection being too difficult or it was set up to fail. That really wasn't the purpose of it. What I can say is each and every one of the homes we went into, while speaking with the staff, they really thought they were doing it right. So we're not saying that everybody was out there intentionally making errors and reporting things fraudulently. There were issues, and we had to think about what are the issues, and we need to fix this. So some of the findings, and I really want to go over this rather quickly, inconsistencies between what was coded in the RIMDS and what was being reported in the resident record. A lot of inconsistency. Overcoding of minutes for PT/OT, especially, we saw a lot of folks, and even now if we look at the data, PT minutes, 3 days, 45 minutes, about, 80 to 90% of the assessments in Ontario say exactly that. Not a minute more, not a minute less. There's also some daily basic routine nursing care that's being recorded as rehab and restorative care, and missing goals and missing plans and missing reassessments. So that was alarming for us because we all thought there was really good communication regarding what needed to be documented and how, and it was realized through this that it wasn't clear, and now we need to look at why and what can we do to change this. So really the steps to improving data quality, and this is the right away, what are we going to do? Education. So we need to standardize education, and while CIHI has a fantastic roadmap, everyone still needs to be doing the CIHI education. We needed something in Ontario that allowed the ministry as well as each home to measure the understanding of the education that's being provided. And so we implemented AIS with the competency modules across the system. Developing data quality tools and support, so we'll talk a little bit more about that in a few minutes. And we felt it was really important to really break it down for homes and give them reports that they could understand and look at their what their results were. Developing ongoing data quality inspection model. We hear this over and over again that this needs to keep going, that we need more data quality inspections out and not just looking at special rehab, looking at everything, because we all want to get better at what we're doing. So each and every one of you, I see you guys shaking your heads, and I love that, because if you're doing something wrong, you want somebody to tell you that it's wrong and you want to fix it, right? So, and building a culture for data quality improvement in Ontario. And this is really what we're talking about when we're saying using your data, thinking about each and every piece of data that's being provided, whether it's through your RI assessment or along the care plan. Everybody who's documenting really needs to be aware of what they're doing and what the impact is of what they're doing, and understand the results coming back as well. So there's a pretty strong need for some communication and some improvement for folks to have that support, and I'll talk a little bit more about how I see this, and I definitely welcome some thoughts around that. Continued partnership with our stakeholders. So I was lucky enough to attend a fantastic meeting yesterday, and that was hosted by OLTCA and ONUS. And they talked about what can we do. It was a special rehab task force. What can we do now to improve this reporting system, the reporting of the special rehab? It was fabulous. It was very, very exciting. So I need to go quicker because I have 5 minutes. So AIS implementation. I won't spend a lot of time on this. You're all very well aware of AIS. I'm very happy to answer questions if you have any. So really what we wanted to do is streamline the education available to staff by having a tool that was going to give us the measurement of understanding, by really giving us the tools to improve education where it was lacking. So it's not we're monitoring, we're out there watching you. That's not what we want you to think. It's really about we need to know where we need to improve things. That's all. So the breakdown of the AIS implementation, it went out in 2 phases, and then there's a 3rd phase starting in April, and the 3rd phase is really going to be focused on who next needs to be put into the system. So we'll be communicating very shortly about that. This is the plan, the lovely diagram that you've all seen, and it also will highlight for you the core competency evaluations that are required for all RI coordinators, backups, and educators. So data quality tools and supports. We have 3 specific areas that we're focusing on. We're focusing on data submission compliance, data quality monitoring, so really detailed level things like, did you get your data in on time, yes or no? Number of late assessments, number of postal codes missing, OHIP cards missing, because that's all really important to us at the ministry for a number of reasons. The data quality surveillance tools that we just rolled out not long ago, and that comes through a lot of work with CIHI and Interrise. So a lot of the work John Hurdy's did in the paper that Natalie spoke to you about that's going to be released is really some of the basis of this report. So it's a great connection there. What you need to know about these reports is they're refreshed quarterly. We're going to have them available for you, and we want to improve them. So if there's something not working, and I know the surveillance ones are a little more complicated than the other ones, and that's okay, because we need to grow the decision support capacity in Ontario. So it will take some time to get used to looking at your data in that way, but we'll get there. We have to grow that capacity. The data submission compliance is just that. It's talking to you about the number of submissions that you submitted to CIHI versus what we expected based on your bed size, because we're getting a census from most facilities. Average is 97-98% being at capacity, and that's the benchmark that we're using. So if you're below 95, we're questioning that. Data quality monitoring, won't spend a lot of time on this one. This is really just breaking it down into those things that I mentioned earlier by individual indicator. And the data quality surveillance report, it's the one that somebody lovingly referred to yesterday as the bingo dabber report. So we're really excited about this one, and this is a powerful report that I encourage everyone to really spend some time getting to know. And if you have questions, use the tools online to really answer your questions, and if you still have questions, let us know. So building a data quality culture, this is where we really want to go. And here's my thoughts around this, is we want to share a data quality approach where everyone who documents, collects, or submits data in the healthcare system is accountable for that quality of the data that they're producing. Creating awareness of the uses of data for planning, for funding, for any other decision. Let's not just be thinking about it for funding. Let's think about it for all the reasons it's being used. And providing data quality tools and supports for each and every one of you to allow you to use your data and to talk about your data. So if you're the RI coordinator in your home, use these reports to have conversations within your facility about your data and about your results. And if it's bad, that's okay. Have a conversation with everybody else about our results need to improve. Let's fix this. So we really want to make data quality a priority, and how we think this needs to happen is we have to take a top-down approach. We have to get the senior leadership's buy-in from this, because they need to support all of you on the front line. And from all of the conversations I've had with senior management folks, they want this. So they are aware of the difficulties, and we all need to work together to figure out solutions to get there. We need to entrench data quality accountability in each person's role. So when people are looking at the ministry or CIHI and saying there's a data quality problem, what are you going to do to fix it? I say it's your data. What are we going to do to fix it? We can support you with some solutions or education or whatever it may be, but it is your data. So we're in this together. We'll fix it together. We'll come up with solutions together, but it's really thinking about that. So, and then maybe providing some tools to ensure that each person really understands the impact if there is an issue, whether it be accuracy or validity in the data that they're producing. So deliverables, what are we going to be doing to get this ball rolling? So shortly there will be a memo that will be distributed to each of the administrators within your facilities in the health system funding series of memos, really talking about a culture of data quality and what we need to do to get it started. There's going to be a framework, and there's going to be toolkit. And in the toolkit we want to do things that are very informative and useful to folks to implement within their facilities, and tangible outcomes, nothing crazy, difficult and complicated, things that are really simple to do, and communication tools and things like that, policies and procedures, and best practices. Because we focus a lot on the negative, we really need to focus on the good stuff, because there are a lot of good news stories that we need to focus on out there. So we want to try to produce some flagship presentation or similar education material where we can hand it to folks out in the field, and it's really going to inform them of each point of data that's collected, what the impacts are, what it's used for. It's going to help inform and improve quality across the healthcare system. And then again, just talking about it, communications regularly regarding data quality issues and products, and you need to use them. So when we had it was funny, when we had the surveillance reports launched, some of the teleconferences had one facility saying, so what if I don't want to look at this report? Well, don't look at it. What can I say? But what you need to know is we're providing the report because we're interested in it and we're looking at it. He said, well, are you going to send the data quality police to come and get me if I'm not looking at this report? Well, my response is you really need to know where your home is ranking in this report, because if the data quality police do come, you want to be able to know what's happening in your facility, that you're so different than everybody else. That's all. So it was funny anyways. But that's it for me, and I just have to say that I know there's been a lot of conversation on the negative side of things for a long time with regards to the special rehab reporting issue, and I see it as a genuine positive opportunity for us to really band together and figure this out together, because I think that there's some fantastic partnerships and conversations that have arose since the aha moment, and I think they're continuing, and I feel privileged to be a part of this. I'm really excited by this. So let's really try to focus on the positives and think about the best practices that we all need to pull out of those nooks and crannies, because we know that there's great stuff happening, and that's the stuff we need to focus on. That's it. Thanks.
I'll bring up the right one here. There we go. Hello. Thank you. Technically challenged. Well, it is a great privilege to be here today to represent Extendicare and to share with you our experience of moving into data quality culture. So we're hopeful that our experience will help you as you begin your journey as well, and perhaps you've already started that journey. And I appreciate everything that the ladies before me said, that it is something that we are all working on together, and it's in our best interest to all do that together. So everything that we do, and there are many long-term care providers in the room this afternoon, and I think you'd agree with me that everything that we do as a long-term care provider is driven by our mission and our vision. And Extendicare is all about helping people live better. That is our mission. And our vision is centered around providing our residents with quality care so that, in fact, they can live better. So when the Ontario government announced that key quality indicators would be publicly reported through Health Quality Ontario, and that performance would make our sector more transparent to the public, Extendicare welcomed that, because it actually aligns perfectly with the whoa. I won't do that again, hopefully. So if I can find this, there it is. I'm more than technically challenged, I guess. So it aligns perfectly with the third element of our vision statement, which is to continuously measure and to publicly report our performance. And we've talked about that a fair bit already. So in response to the significant challenges and changes that were occurring within our sector over the past few years, Extendicare undertook an extensive effort to align our systems and policies to meet the new initiatives. And that included, but is absolutely not limited to, preparing our homes to meet the new long-term care legislation and the regulations that were introduced in 2010, and adjusting to the new compliance inspection system associated with compliance transformation. We also began to focus on measuring clinical outcomes, given that we now had the availability of CIHI data. So by mid to late November, we could pull that data from CIHI, and we began to take a closer look in terms of the story that that data was telling about our homes. And quite frankly, the story that it was telling us at that point in time was rather troubling. It was troubling, it was puzzling, because what we saw from the data, we did not believe that it was accurately reflecting what we thought we knew about our homes and what was happening as far as the provision of care and clinical outcomes in our home. So, we really began to question ourselves and ask ourselves some really serious questions about, well, are we really meeting the mission that we've stated that we're all about? So to address the poor showing that we saw through the data, we began risk assessments. We reviewed our clinical practices. We reviewed and revised policies and procedures, and we provided a great deal of additional education to our nursing staff. Our homes, they were engaged, they were receptive to the whole process, and they were definitely motivated to improve. However, from quarter 3 of 2010 to quarter 2 of 2011, we actually witnessed worsening performance as related to some of our indicators, and with other indicators, the data remained flat. And, that's really not something that an organization wants to see happen. But I will tell you, and you look at the top line, that's Extendicare, and the bottom line is the provincial experience, the provincial average. And so you can imagine that this was a little disconcerting when we saw it. But if you are at the point right now where you are beginning your data quality journey, I will tell you that this is not going to be unusual. Because when you start applying a deeper focus, a more intense focus on any indicator, on any area, that increased awareness also more than likely is going to cause an increase in identification. And that's not that unusual. But I'm not trying to dismiss that is the only reason. There were a lot of things that were going on. But just don't be afraid to start asking the difficult questions, because that's exactly what we need to do to get to the answers. So as an organization, we realized that, this is not going to be a quick and easy fix. And it really left us with the question of, do we have a data accuracy problem? Is that really what's going on? Or in fact, is there something related to quality? Is there a quality issue that we are dealing with? And so, we really needed to know. And in order to get that question answered, or to help us answer that question, we turned to an organization out of the U.S. who had over 20 years experience with RIMDS 2.0, and their name is LeaderStat. And together we developed an approach that resulted in the execution of targeted data audits in all of our homes across the province. So the way that we approached this auditing was that we selected 5 clinical indicators that we believed were really important to measure resident care and clinical outcomes. So those were the focus for the auditing. And specifically, they were daily physical restraints, worsening pressure ulcers, falls in the last 30 days, worsening bladder continence, and worsening pain. Now, in addition to those 5 reportable clinical indicators, we also targeted the late loss ADLs because of their impact on the CMI, which of course we're all interested in. So then we chose data accuracy targets, and this came from collaboration with Leaderstat as to what was realistic. And we chose a sample size of what our auditing should be, and we then began all of the audits. And our clinical consultant team was very involved with Leaderstat. As a matter of fact, it was basically a train-the-trainer type of program, so that then after we were trained, we would be able to assist our organization to sustain the process. And I think that with anything that we do, we have to look not only at the initial effort that we put into things, but we have to look at the sustainability. So our audit focus, and I appreciated the comments that were made earlier, our audit focus was on the documentation necessary to support coding. Because you don't code in a vacuum. And you have to have the supporting documentation. So we looked at adherence to the rules and the regulations of coding in our audit practice. So what were the results? Well, this is, you're probably all familiar with a scatter chart. And just to give you a bit of orientation to it, the x-axis along the bottom represents our error rate, and the y-axis on the far left represents our clinical indicators. And so when we plotted out the results of that first audit, this is what we got. And again, it was a little less than what we had hoped for. So when we look at it, it'll highlight the different sections. This group of homes, you can see that some of them, their error rates were pretty significant over here, and they were in the high of the clinical indicators. So that wasn't really where we wanted to see our homes, right? And so down here, let me do that. So down in this quadrant, well, the clinical indicators look better, right, over here. So we're down in the area where we would think that the clinical outcomes are better. But really and truly, we're still dealing with error rates. And I don't know if you can see that or not, but that says 60%. And so that's pretty significant, right? So that is troubling as well. So and we really wondered then. So then up in the top left-hand quadrant again, we have homes now that are in the better accuracy rate, and our accuracy target is measured by this red line here, which we set at a minimum of 85%. So now we have the error rate is low, but we still have clinical indicators up here that really aren't meeting our target. And then down here in there it goes, in the green quadrant, where we have the low error rate and the low indicator, that's good. But unfortunately, as you can see, only 2 homes made it into that green box. So we knew that we still had a lot of work to do. So this isn't really an excellent tool. We were asked to share some of the tools that we have used in our journey to help us. What the heck happened there? Okay, let's just move forward here. I probably touched the. They'll never ask me to do a presentation again. You see, I planned it this way. You have to do something to. Oh, dear. Anyway, so moving right along. Okay, so I'm getting away from that thing. Okay, I'm going to stand back because obviously I'm touching something that I shouldn't be. Okay, So so what did that tell us, right? So I mean, you can have all kinds of wonderful tools, but you have to know what it's telling you, and then you have to know what you're going to do about it. So we discovered that there were numerous factors affecting our data accuracy. And, this is not by any means an exhaustive list of the things that we discovered. And in the interest of time, I'm only going to touch on two of the points that are on the screen. So one of them was that we found out through doing the auditing, because as I said before, we were focusing on the documentation to support coding. You don't code in a vacuum, right? So one of the things that we found was inconsistent applications and misunderstanding of RIE definitions. So for example, the definition of P4E, chair that prevents rising. We found that this was particularly problematic for our staff, and actually we felt that it led to a higher coding of daily physical restraints than probably what should have been coded, which was, what was actually accurate. So just because the staff didn't understand the definition, they were coding it inaccurately. But that wasn't the only definition that our staff were struggling with and that we had to go back and do re-education on. So don't just assume that your staff understand all of the definitions. They, in fact, may not be interpreting or actually following the definitions accurately in their coding. And then the second point that I'd like to speak to on this slide is that frequently during the audit process, we found that staff were coding based on what they thought they knew about the resident. So it wasn't substantiated in the documentation, but when you talk to the staff, we just know that that's the way Mrs. Smith is. Right? But when we looked in the documentation to support the way it was coded, there was absolutely no verification that we could find that would suggest that that person should have been coded that way. So again, it really is an important thing that we really look seriously at as what's behind the coding. I don't know does this slide at all look a little blurry? Probably to some of you in the back, it is. But you know what? I thought after I looked at it again, I thought, you know what? It's good. I'm glad it's blurry because the reason for my saying that is that because during this period of time, it was like we were in this blur. We were in this blur of activity. And you know what? This only represents a small portion of the actions that we took. We found out what the factors were that were contributing. Well, then once you know what's contributing to your problem, right, you have to take action. And really as the consultant team, we were on a fast-paced blur of activity. But you know what? When I say blur of activity, it was not that it wasn't purpose-driven, and it wasn't that it wasn't goal-directed. And everything that we did, all of that, plus more, took us through a process of moving in the positive direction towards where we can now say with confidence that we actually know that we've achieved what we set out to achieve. And that's what it's all about, right? So, again, in the interest of time, I'm only going to speak to two issues that are on the screen, and I chose the two that I personally felt because of the homes that I have, and I have 5 homes that are my responsibility in the Southwest region. So I chose them based on what I've seen in my homes that I really believe has made a critical difference. The first one is daily clinical interdisciplinary morning meetings. And I don't know if you were in this room this morning, but if you were, you heard a lot of things about interprofessional collaboration. And that's what this is all about. Daily clinical interdisciplinary, whether you want to use interdisciplinary or you want to use interprofessional, to me it means the same thing. Maybe there's some fine differences, but and I'm not talking about shift report, by the way. So these are meetings where we bring the whole interdisciplinary team together. It's an excellent way to focus everyone's attention on changing residents' conditions. And by doing that, we're ensuring timely and thorough follow-up by the entire team. So it's not a nursing-driven focus. It is everybody. Physio, programming, everybody is at these meetings. And we use High data to help us to direct the focus that we're taking. So if somebody has had their MDS assessment and they've triggered for worsened bladder continence, why? Why did they trigger that indicator? And what have we done about it? Have we done the correct assessments? And did we update the care plan? And all of those important things. And then secondly, I believe of critical importance is that our homes have taken ownership of the process. And so management really is completely engaged in this, whereas in the beginning, we really, in a lot of cases, handed it off to our RI coordinators, and they were carrying just a huge and intensive load. And you cannot do it unless your entire team is engaged. Okay, so that was sort of leading us up to, okay, so where are we now? So the past 12 to 18 months, yes, it's been extremely intense across the organization, and we have now completed our third data quality audit in all of our homes, and we are finalizing our fourth as we speak. So here is the good news. So we have witnessed incredible and significant improvements in our data accuracy. And I'm only going to just mention a couple of these here, but if you look at the far left, that is the late loss ADLs that I mentioned that we were also focusing on. And it shows 3 bars, so it represents each of the audit phases. And you can see that by the time we got to our third audit, we had experienced a 63.5% improvement in our data accuracy for the late loss ADLs. Moving to the next set of bars, that is the worsened bladder continence. And over the course of the 3 audit phases, we have improved our data accuracy by 53.1%. And the most significant improvement has been in the area of worsening pain. And over the course of the 3 audit phases, we have seen almost a 70% improvement in data accuracy. So some pretty, in our opinion, some pretty significant improvements. So this is another way of reflecting the accuracy and using just a little different format, so the pie chart. And I want to just draw your attention to the far left-hand side of the screen. And I want you to look at the green triangle. And so, again, it represents each of the 3 audit phases. And so the green triangle represents those homes that met the data accuracy target for 5 or 6 of the 6 elements that we were tracking. So in the first audit phase, you can see that only 1 home made it to meet those targets. And then as we progressed through the next phase, we had 3, and now with the third, we've had, my gosh, sorry. So with the third, we have had 12 homes. And so each section of the pie represents homes that have achieved different targets as far as the 6 elements. And in completing our 5 minutes, and in completing our fourth audit, we've actually seen a significant move to more of our homes will show up in that green section. So we've talked about our improvement, and we also not only want to focus on the error rate experience that we've had, but we want to focus on the clinical outcome experience that we've had. And again, we have made some significant improvements in the outcomes. So really the chart is fairly self-explanatory, but if you remember that scatter chart that I showed you, where it was talking about worsening bladder continence, that had a 60%, almost a 60% error rate. What we have seen as far as clinical outcomes as we've moved through 2012 is that we've improved our data accuracy rate in the area of worsened bladder continence from 60% error rate down to less than 18%. But we've also decreased the incidence of worsening bladder continence by 20%, which is the middle bar. And this is a chart of the restraints, the quality indicator for daily physical restraints. And extended care is represented by the blue bars. And over the course of 2012, we have seen a 31% improvement as far as the reduction of daily physical restraints. And that is compared to the provincial average of 15%. So the error rate, moving back to that again, we have seen over the course of 2012, we have reduced our overall error rate from a 7% down to 4%. And again, this is for daily physical restraints. And our ultimate target, so we have set new targets for 2013, and our ultimate target now that our homes are challenged with is to bring our error rate to 3% or less, with the emphasis on or less. So the blue triangle on this screen, again, this is showing daily physical restraints. The blue triangle represents that experience that I was telling you about when we first started looking at our data, where it was steadily climbing. But if you will notice, however, that as we move to this side of the screen, it has reflected that over the course of 2012 now, we actually have dipped down below the provincial average. And so our target is actually represented by the black line along the bottom of the screen. So, when you really start measuring what you're doing, at first it can be a little scary and unnerving, but as you progress through the process, then you start realizing that all the efforts that you're making are having some really positive outcomes. And you know what? You can take a chart like that to your restraint and falls committee, and you can show them what good things are happening because of all of the work that they are doing. And that is a real motivator for your staff to be able to actually, get them excited about all of the quality efforts that you're doing. So we have found over the course of our experience that there is a direct correlation between accurate data and improved clinical outcomes for our residents. So I just wanted to share with you briefly another tool that we use, and this is actually a tool data that comes out of our software documentation system, because as we know, the data that we get from High can be upwards of 75 days after the close of a quarter. So you want to be able to react faster than that. And so we use the quality indicator reports that are built into our documentation software, and we're able to then, in a very timely manner, as a matter of fact, as soon as a MDS assessment is closed, we can actually run the report and we can see what's going on. So over here, we have a group of about 13 homes, I think, that are there, and these are the homes that have they've met both the clinical outcome targets as well as achieved their data accuracy targets. And for this particular indicator, which I'm not sure you might be able to see up there, it's for worsening pressure ulcers, our error rate target was 5% or less. And then moving to the second group of homes, so although they've attained the accuracy targets, they haven't met the target that we set for the clinical outcomes, and that was 1.9%. And then finally, on the far side is a group of homes. Yes, they're still struggling. There's still things that they are dealing with. And the one thing that we know, because their error rates are so high, is that really their clinical indicators cannot be considered credible. Because of the error rate, right? So if you have a high error rate, then really what is that doing to the outcomes? So we believe that, with further work, we'll bring them into this over here, this side. So to wrap up then, quality outcomes in the future, well, we know from Extended Care's perspective that our journey isn't over. As we go into 2013, we have set new and more aggressive targets for each of our homes to achieve as far as error rates and clinical outcomes. But the future is clear for all of us as long-term care providers. Better quality outcomes in concert with the effective utilization of available and limited resources. So I think everybody, hopefully, I certainly would say it with emphasis, is that long-term care is a vital player in the healthcare sector. And we know that our role will be redefined over the future, but you know what? We need to be excited about that too. And we are. And our journey has demonstrated one thing, that attaining data accuracy, it's complex, it is hard work, and it does take a lot of effort. But in our opinion, it is absolutely the right thing to do. It's the right thing to do from the perspective of the providing health care to our residents. It's the right thing to do as far as the public, and that's you and I in this room that pay for the health services. And it's the right thing to do for the benefit of policymakers who are making decisions around the data that we provide to the system and also to the funders of the system. So just to conclude, I do express my appreciation for being able to share with you. Apologize for all of the gloops and the bloopers. But anyway, hopefully you've been able to see that, putting that amount of effort into a process is very worth it, because at the end of the day, you will know that you provide quality care to your residents, and you'll be able to support that and show it to your family members and to whomever might ask you. So hopefully our journey will help you on your journey, and again, thank you for the opportunity to share our journey with you.
Thanks, Pat. Thank you to all three of you, Stacey and Natalie and Pat. If there's any questions that anyone would like to pose to any of the ladies, we have a microphone in the back of the room, and ask it that you would use it so everyone can hear your question. Go ahead.
I'm just wondering, I do get the reports that the ministry does release with the CAI data. If there's been any tools that homes can use to look at the data before it gets submitted to CAI.
So there are no tools that have been developed because it's probably not been a huge priority. So it's a great point that you're making. If you have ideas and thoughts, I would encourage you to contact me. I know that there originally, when the project was implementing raw MDS across the system, they had a few tools involved there, but I don't know how deep it went in terms of evaluating your data prior to submission. So it's definitely something worth exploring, but it's not. We've been really focused on the after using the data, this is what your data says, but it's a great idea.
Yeah,
thank you.
I work for specialty care, and we are looking at something, but I was just wondering if there was something that we're not
I'm definitely interested in talking to you.
Sure.
So if there's I would much rather us work together on something that's fantastic and make sure that we can make it available to everyone. So happy to have the conversation. Yeah.
Any other questions? Oh, got one from the back.
Hi, quick question for Extendicare. Did note that you have had a substantial drop in your falls rate over time. We're just wondering, how did you do that? Was it a data accuracy issue that you were finding, or was it a change in clinical practice?
To be quite honest, it was both. And one of the things that we have found is that once we realized that, one of the things that we found was that once we basically eliminated the coding errors and we knew that we were dealing with accurate data, we then focused on how do we use that data. And we have determined basically for every one of the indicators is that having a committee process in place that is looking at the incidents, evaluating the incidents, and looking at the interventions. And for some of the indicators, you're using your outcome measure scores and using all of the data that is actually provided through IMDS and using the committee process and then sharing that with the entire staff body so that everybody is focused in the same direction. So I really can't overemphasize the fact that what was spoken about this morning as the interprofessional collaboration or the interdisciplinary approach, it is absolutely critical with any of the indicators. And we never really are going to wrestle any of them to the ground as far as really having good clinical outcomes unless we're involving everybody. And I mean, I'm a nurse, and, you know, I always like to think that nurses are the best. But you know what? That's not true, because without all of our partners, we can't do what we do, right? And so if we're not involving everybody else on the team and really using that committee process and meeting frequently enough to look at the incidents, then we will miss the boat, and it will be to the detriment of our residents. So I don't know if that answered your question, but hopefully it was helpful.
Go ahead.
Hi, I have a question for Pat. Thank you for sharing your story. That was very positive outcomes. Can you possibly describe how you calculated error rate?
We used the tool that LeaderStat developed for us, so it was an auditing tool, and there were specific criteria. As I mentioned in the presentation, the focus of the audit was to determine if the coding was actually based on the documentation, so the rules for coding. So let's say, for instance, we were looking at the accuracy of worsening pain. So in order for a person to code, and we know that there's intensity and frequency, so we needed to have the supporting documentation in the clinical record to say what was the pain daily, was it more than daily, what was the level of pain. And so we had built into our auditing tool the specific criteria that we would have to find within the documentation to say, yes, this person coded this accurately. So for each one of the indicators, you have to determine what is the supporting documentation that is required to substantiate the coding. And as I said, I think a couple of times, we don't code in a vacuum. We don't just sit in an office somewhere and say, well, I think Mrs. Smith is like this. And then do we have any notes in RIMDS if the documentation really doesn't support the coding? So in the case of, for instance, with ADLs, if you're coded as frequently incontinent and the person that's doing the coding says, gosh, I don't think that that's Mrs. Smith at all. So then you have to go out and you have to verify with the PSWs. Let's talk about Mrs. Smith. What is her actual status as far as her incontinence level? And then you would do a note in the RIMDS, right? So if, in fact, we found the note that then verified the documentation, we wouldn't count that as an error, right? But if there was no note to explain why the POC documentation, point of care documentation, didn't match what was coded, it was considered an error. Does that help?
We have time for one more question, and then I will ask that our panelists stay back for any other additional questions that people may have. Go ahead.
Okay, I'm going to be real quick. Is there a website that we can really access your presentations, because they were highly informative, but some of them went a little bit too fast for us?
My understanding is that all of these presentations will be made available on the OLTCA site, so they'll be readily available to you, that you're more than welcome to.
Okay, good.
They made us go fast.
I understand.
Yeah, there's so much information to be
all
shared.
day.
So again, thank you very much, ladies. This has been great, and it certainly has impressed upon us the importance of data accuracy. Just as a reminder, there's a very short break now between now and the next concurrent session. I would remind all of you to go downstairs. If you haven't seen the posters, have a quick look, and to place your ballot for your favorite poster. And the next session starts at 2:55.
Came to the best session. Look at this great attendance here this afternoon. A topic certainly near and dear to our heart, and I'm sure those that we serve. Resident experience, resident quality of life. Welcome to the concurrent session, and we have had construction in this room today. You hear the woodpeckers there. I can't do anything about that, but we'll speak a little louder where we need to. Otherwise, be patient. It's intermittent at the best. My name is Joanne Dykeman, and I'm a member of the Ontario Long-Term Care Association's Quality Committee. Today, your moderator for this panel, as well as one of the presenters. So once I actually set up the conversation and we'll introduce our panel, I'll join them at the table as well. And then we will come back to the microphone at the end. What we found through the concurrent sessions is that it's really about the questions at the end. It's the opportunity to ask questions in the dialogue. So we're going to do our best to stay to the time that's allotted and allow that Q&A time to shape up at the end for your questions, okay? To that end as well, then, we'll actually hold questions until we finish off and hear from our rich data panelist here. So without further ado, let's hear from the panelists by way of introductions. And starting with you, John. There is a mic on the table. I think we can actually...
So I'm John Hurdes. I'm a professor at the School of Public Health and Health Systems at the University of Waterloo. And I'm a fellow and board member of the INTRI Research Group and do lots of work in long-term care, home care, and mental health are my primary sectors that I do research in.
And I'm Karen Simpson with the Ministry of Health and Long-Term Care, and I'm one of the senior managers with Mary who are responsible for compliance and enforcement in long-term care homes across the province.
Good, thank you. And I'm Mary Nestor, a colleague of Karen's. The two of us oversee the inspection program for the province.
And I'm Dana Hardy. I'm the National Director of Quality Improvement for Riviera. I'm Joanne's colleague and also the project lead for resident and family satisfaction surveys for our company.
And just summarizing that, Joanne Dykeman, Vice President, Clinical Services and Quality for Riviera, working with Dana on resident satisfaction. We'll now ask John to come to the microphone.
Thanks, Joanne. It's great to be here. I'm here presenting work that was in part presented in previous years at sort of earlier developmental work on quality of life. This research is work that I did with my colleague John Morris at Hebrew Senior Life, and I should also acknowledge my colleague Dr. Vai Kiyan, who's in the audience, who's also been very active in doing this work, so this builds on some of his research as well. So what I'd like to talk about is the work that INTRI did to develop the quality of life instrument, the items and the summary scales that are measured, that are included in it. But I'd particularly like to sort of show some examples of how we can use this for benchmarking purposes, for comparisons between sectors, as well as internationally, to talk about the issue of risk adjustment, and then end with talk about the notion of perspective and quality of life ratings and what we can and cannot do when it comes to using information from alternative informants. So for INTRI, we're really interested in quality of life from at least two different perspectives. There's a dimension of quality of life that you can measure objectively. It's externally knowable, and it's not hard to see what those things might look like. So if we were to look at people in some of the more unfortunate areas of the world, things like starvation or poverty or abuse, you can sort of see that by measuring it from the outside. You don't have to have a rating from somebody in Syria today to know that things aren't so great overall. On the other hand, there is a subjective dimension that is very person-specific, is very idiosyncratic, and you do want to get the person's view on that in the form of self-ratings from their perspective. And one of the interesting things is that the two don't necessarily fully coincide. They do give you different views of quality of life overall. But you really can't afford to ignore either perspective. So if we think about the INTRI assessment instruments, there's lots about quality of life in there. We just don't necessarily label them as such. But if we think about this externally observable, objective dimension of quality of life, we can rate other people's pain even if they have cognitive impairment, and we know that those pain ratings are an important dimension of their quality of life. ADL, depression, social isolation measures, sleep measures, conflict. There's lots and lots in those assessor-rated clinical assessment instruments that's very pertinent to the notion of quality of life. But that's not the main focus of what I'm talking about today. What we're interested in from the subjective point of view is we want to know about individual experiences. How do residents in long-term care facilities describe their quality of life on that subjective dimension? And how does this vary between organizations, and how does this change over time? Do people get better? Do organizations perform better? Those are all interesting questions. Now, There's lots and lots out there about satisfaction surveys. I remember recently being at a Hampton Inn, and they said there's 100% quality guarantee. It's 100% satisfaction. Anything less than that, they won't stand by. It's got to be 100%. I had my car fixed at a Honda dealer, and the maintenance person gave me a survey and said, fill this out. There were 10 different questions to rate, and he said, by the way, if you rate any of those less than a 10, let us know so that we can make it a 10. Otherwise, we're going to have problems with our management, and we'll give you a free car wash if you do that. So this is meaningless, right? It doesn't tell you anything because it doesn't really measure what's going on. It's an artificial attempt to get a false sense of security and reassurance. Maybe it's good for marketing purposes, but it tells you nothing about quality in those organizations. So our surveys have 47 different questions dealing with 10 dimensions of quality of life, and we've also summarized them into 3 main scales. There's 2 sort of key summary scales. One that deals with the overall sense of comfort. This is a comfortable place to be. I like the food here. Those kinds of questions, and then there are questions that deal with day-to-day aspects of life, like how staff treat you or interact with you, how whether you have meaningful activities to pursue. And those 2 scales comprise 30 items overall. We do have a short-form version of it that's just those 2 scales plus one other personality-based risk adjuster. So you can do it with as few as 31 items. We think the 47-item version is a little bit better. It gives just a little bit more information that people find useful. So these are the dimensions that are covered. And you'll see there's not that much that's different from other surveys that you might be familiar with. And this literature is a good 50 years old. The research on psychological well-being, life satisfaction, quality of life started before I was born. And, there's been a lot of research that's happened on there. And people have tended to cluster on these as important domain areas. It's the items and the scaling within it that is where things are a little bit different. So the way we derived our scales was from using multinational data from different types of organizations, and we did fancy factor analysis to get those 2 scales. But the important thing is we independently validated those scales using independent samples. So we derived it initially with our international data and then did replication with an independent analysis of survey data that came from a research project that Vahi led as part of his doctoral dissertation, and we're now actively working on papers from that. So the comfort scale, as I said, sort of deals with sort of an overall view of things that relate to how comfortable you feel in the organization. I'll show you some examples for a moment. And generally what you see is if you can convert this to a positive response, about 70 to 75% of residents will tend to respond positively to this. This is a single organization collaborating with us in the U.S., and you see their distribution is located around the 8 or 9 score, but there's a fairly long tail in terms of their distributions at different point in time. What's interesting for them is the proportion at the higher end of the scale was dropping over time. They're looking into, is that a real change? What have we done that for some reason is driving this down? But this is sort of a typical distribution you'll see in the quality of life scale literature in terms of those distributional properties. These are the kinds of items that are in the comfort scale, things like I feel safe when I'm alone, I'm treated with dignity, I get services I need, are ones that tend to get more positive responses. But then there's other items like staff act on my suggestions, so about a 65% response rate. And then this place feels like home to me. Well, that's one that only gets about a 50% response rate, even though that is intended to be a pervasive part of our philosophy of what care is. Only about half the residents are agreeing that, yeah, this place feels like home to me. The aspects of daily life scale deals more with sort of interactions with others and sort of day-to-day activities in the organization. And what you see is it tends to get a more skew to the left distribution. It's more centered on the score of 6. So these are tougher questions to say yes to. We deliberately built in items that are not going to give you the 100% satisfaction. More difficult questions to respond positively to. So we don't just say, do you like the overboiled mashed potatoes here? It's, do I get my favorite food here? That's a harder standard to achieve. Do staff know the story of my life? Do people ask me for help or advice? This is an interesting concept from the literature on reciprocity that shows that's important to feel like you have something that's valued to others, and not just that that people are being nice to you, but you've actually got something to offer. And for that item, you see only about 35% of residents are saying yes to that. So when it comes to benchmarking, it begins to be kind of interesting when you have cross-national data. So this is from an initial study of mainly Canadian long-term care homes. Part of it came from Vi's dissertation. Part of it came from work we did with the Schlegel homes. And what this shows you is the distribution of the two scales. It's always the case that the aspects of daily life scale has a lower mean score over time compared to the comfort scale. But you notice there's quite a bit of variability. In this home, the mean score is around a 4.5 compared to around a 7.2 in that home. So even when you look at the average scores in these scales, you do see variability between organizations. This has just been published in the Long-Term Care Association magazine. It's sort of an interesting one. This came from the project we did with the Schlegel homes. So what we did is we looked at the different dimensions, and we looked at, what percentage of people reported positively on 3 indicators in that dimension. So it's a different way of making it a little bit more difficult. And what we've got is the chain performance, and then the performance of a specific facility within the chain. So you don't only have to benchmark against a province, you can also benchmark among a peer group. And what you see is that these dimensions of respect, comfort, safety, and autonomy, it's sort of middling to okay. These other dimensions tended to get less positive responses, but this home within the chain didn't do as well as the overall chain performance. And that's for their nursing home beds, and then this is for the retirement home beds, which tended to have a bigger area overall in terms of the positive scores. The similar areas populated where they were more positive compared to other areas where they were less likely to get positive marks in all 3. And then in that same home on the retirement home bed, still not doing as well as the overall chain. It was just a slightly different view of benchmarking. One was stack up organizations, look at mean scores. This tends to look at overall performance on different dimensions. It's a slightly different view. You can also take a look at, what percentage of people scored very high on the 8 to 10 of an 8 to 10 on the aspects of life scale. And now we've got more international data. We have data from Czech Republic, Estonia, Australia, South Africa, many Canadian organizations, Poland. The DPHs tend to be U.S. homes. So we've got a lot of variability now in terms of the countries represented. And I chose 2 homes. South Africa is where I was born, and then this is a Southern Ontario home. So I thought, okay, well, it'd be interesting to see the start and end point. So this is looking at, so the top end of that tough scale. And for the South African home, only about 10% of their residents were 8 to 10s on that scale, compared to this home around 35%. This is a U.S. home at around 80%. So tremendous variability there in terms of that fairly difficult scale. But then if I look at the bottom end of the scale, the rates of people that are reporting very poor scores, if you will, the South African home also tends to have fewer people at the bottom end, and now the Canadian home that I highlighted earlier moves fewer at the bottom end. What that's saying is that the South African home tends to have more compressed scores toward the middle rather than being on an extreme either way. Then we can take a look at individual items. So we can look at scale summaries, but it's also interesting to look at individual items. And so this is, this place feels like home to me. In this case, in the South African home, around 41% said yes. In the Canadian home, around 75% said yes. The Estonian and Czech homes didn't do so great, but the fourth home was a Canadian home at around 30%. And this was a Canadian home at around 90%. So lots of within-country variance and lots of between-country variation. This is, can I bath as often as I want? And in this case, we see here's the South African home. In the top 5 or 6, beating many, many different Canadian homes. So it's not always the case that performance in one dimension means that you're better in performance in other dimensions. There's a good explanation for this, that in fact, in the South African homes that we're working with, they have a fair bit of difficulty getting regulated professionals for staff, but they have no problem getting lots of PSWs. So they have a much higher concentration of PSWs per resident than we will have in the Canadian context. And you see it in terms of this kind of change in preferences. Can I engage in meaningful activity? This time the South African home is in the middle. That Canadian home that I highlighted earlier is closer to the top. But this South African home with not that many resources is doing better than many, many Canadian homes. What this graph does is it orders it by this place feels like home in the pink, and then just shows you the rates for the other things. And what you should see is noise. What that noise means is that these concepts don't all go in the same direction. It's not people are saying the same thing for every item. There's differentiation happening, and positive performance in one area may not necessarily translate to positive performance in another area. Now, Vahi's dissertation was very important because it opened the question of risk adjustment for quality of life ratings. We know that if we're doing benchmarking on pressure ulcers, on falls, on ADL, and so on, we've got to risk adjust because there are population differences. But what Vahi's dissertation showed is that there's also factors that you pick up in the REI that are related to performance and quality of life indicators. And so some are attributes, individual attributes that might have an impact on quality of life, like cognition and ADL are important. There's some that might be a part of quality of life. So how do we deal with depression? If you have a higher rate of depression, do you risk adjust for that? Or is that, in fact, another dimension of quality of life in your organization? And then the other thing from this literature that's now 50 years old is we know that personality traits are very strongly associated with rating patterns, and Vahi's dissertation showed that. He's a very grumpy guy, so he always gives negative ratings. I'm a cheerful guy, I give positive ratings. If you know Vahi, you know that that's not at all true. But you do need to sort of think about personality traits because, you know, the literature says they have a role, and his dissertation showed that was the case. I'm going to end off with looking at things from a variety of different perspectives. So we have this problem of sometimes people don't respond to those surveys. Sometimes it's because they don't want to, they refuse. You can deal with that through good quality methods and finding ways to engage the person so you get a decent response rate. But the trickier part is people who are cognitively impaired, who have impairment in communication. How do we get information from them? And the question has come up, well, can we get another person's perspective and substitute it for people with severe dementia that can't respond for themselves? The issue about quality of life is that perspective matters. So it's the old story of, you know, the blind man looking at the elephant. They each see a slightly different thing. We did a study with 24 homes in Nova Scotia where we did 3 versions of our quality of life survey. We did the conventional resident-rated survey. Then we had a parallel survey that family members answered in terms of my family member. You know, staff are nice to my family member. And then we had a staff survey that says staff are nice to residents. Staff are nice to me, staff are nice to my family member, staff are nice to residents. And we wanted to see how they corresponded. If we look at the resident ratings, we see high ratings for things like, I consider a staff member my friend. Lower ratings for staff, people ask me for help or advice from residents. If we look at the family ratings, they tend to be more negative all around. They tend to be more pessimistic, more negative in those views. And then the staff tend to be more positive or about the same on some. There's 2 interesting ones here. I've got a social worker on my staff who I love to antagonize whenever possible. And so this one's interesting. I consider staff member to be a friend. The residents are more, 60% say that, 70% of family members, or residents say that 70% of the time, family 60%, staff 50% of the time. And so, you know, my poking at her said, it's sort of like, you know, the Stepford Wives nursing homes. Everybody looks friendly, but there's not really that engagement. Is that an issue? You know, so do our professional boundaries, you know, give sort of a false sense of affection, or is there something genuine going on there? And you know, do we care about this difference in these ratings? The other one that I find kind of devastating, actually, is this one on I play an important role in other people's lives. The residents said that 40% of the time, which is sad in its own right. staff were kind of Pollyannish on this, in the sense that 60% of the time they agreed with that. It's sort of like, yes, of course, people value our residents. Family members only said that 20% of the time. And you can do something about this. You can work with family members to say, well, here's something you can do to really engage your relative in the day-to-day life of your family so you feel like they're playing an important role in your family. It's not just coming by to visit periodically. So the bottom line about substitution is that it's good to get information from different perspectives, but they're not interchangeable. It's worthwhile to do this, but don't substitute one for the other. Don't assume that a family member's rating is the substitute for somebody with severe dementia who cannot respond. We've got to find ways to maximize participation, but there's a point at which we say, okay, a standardized survey methodology won't help me with this subgroup, so I find another way to get at that information for that subpopulation. Where we're going next is there's lots of papers that we're working on for the peer-reviewed literature. Vi's got a couple already under review. We're bundling our quality of life instruments with our new Inter-I instruments as part of an integrated suite if you want to use it at the person level. We're beginning to do lots of benchmarking. So between Hebrew Senior Life and University of Waterloo, we are actively recruiting organizations to work with us to expand this now as a benchmarking network, similar to what we heard in the Senior Quality Leap Initiative earlier on. State of North Dakota has adopted it as their instrument standard, and we have a psychiatry version that we're testing now. So, thank you.
We're going to now ask Mary and Karen to come up and hear from a slightly different perspective, and equally important, the voice of the resident during the survey. Which one would you like? Mm-hmm. Where have you got there? The second from last. There we go. That's the one. That's it. Just give us
Okay. Very good. Thank you very much, Joanne. Actually, Karen and I are going to indeed sort of switch up the perspective right now, because we're going to focus on a few key aspects of that are stemming from the inspection process itself, which could point to some areas for clues about resident and the family experience. These aspects are quite a little bit different, and obviously from a different perspective than what you've heard from John and his presentation, in terms of not being determinants in and of themselves, but they'll provide us with some vital clues and information from which we can either infer some conclusions about experience or at least draw some preliminary conclusions. So one of the first things we'll want to talk to you about is the role that the resident interviews play within the RQI, the Resident Quality Inspection. Those are the stage 1 interviews, so we'll talk about those, and then we'll just kind of slip into talking a little bit about the connection with continuous quality improvement and what the connection is between those two. We'll talk to you a little bit about the complaints process and what we can learn from some of the complaints information that we've got at this stage, and then a word about residence councils and family councils and how their role within the long-term care home, how they contribute to affecting satisfaction. So just to set the resident interviews into perspective, we've got a slide here that just puts those, gives you an idea of where those resident interview questions kind of fit into the bigger picture. So this is just a little bit of information. It's kind of background, and for many of you this will be repetitive information that you've got already because you've either yourselves already had an RQI or had accessed all the information, of course, that the ministry has provided in terms of the inspection process. But our inspection process, the entire LKIP program, the Long-Term Care Homes Quality Inspection Program, is aligned, of course, with the Long-Term Care Homes Act, the legislation, and with that that, though, within the LKIP program, the RQI, which is the Resident Quality Inspection, that inspection process forms the cornerstone, and we actually say the foundation of all of the other types of inspections that we do as well. So the RQI has a very strict methodology. We've aligned all the rest of our inspections, complaints and critical incident inspections, follow-up inspections, to the general methodology of the RQI and the principles that are embedded within it. And interviews with residents, talking to residents, is one of the key features, first of all, that's built into, very formally, into the RQI itself, and then also features as part of the inspection process in the other types of inspections that we do. And the resident interviews within the RQI are conducted during what's called stage 1 of the inspection, of the RQI. And these questions are set questions. They are validated, research-based questions that form part of that inspection methodology. The inspectors have a script. They have specific questions that they ask, and they ask those questions of 40 residents during an RQI. And the information that we gather from those questions is one aspect of a larger series or larger data input that then we use to inform. It sort of moves into a back-of-house algorithm for the inspection, the technological aspect of the inspection process, or the technology that's used, and then that then informs the inspectors what to look for and where to focus, because it triggers through an algorithm. It triggers through to a stage 2 inspection. So the message that we've got for you today in terms of how this fits into thinking about the resident and family experience and what lessons we learn, what data we gather, is that when these questions are used as they are designed within the inspection program, in and of themselves, the responses to those questions do not give us information directly about the resident experience or the family experience, for that matter, because the responses to those questions feed further portions of the inspection and where inspectors need to focus the stage 2 more in-depth inspection and follow through on inspection protocols. And that's a very, very important concept, because we are tempted to look to those responses to give us clues about the resident experience. However, it's very important to note that inspectors at stage 1, after they've conducted the resident interviews, they cannot and do not reach any conclusions about compliance or non-compliance. So in and of themselves, those responses do not point to a compliance or non-compliance. What they do is trigger, along with the other data inputs, through to stage 2, and that's where compliance, non-compliance can actually be determined through a further inspection. And I think, Karen, you wanted to say a few words as well about those thresholds.
What I wanted to be able to say was that these are yes-no answers. There's no gradation in responses. So I think it's really important. There seems to be this sort of assumption that these are, as Mary has said, some kind of a resident of family satisfaction, and they're not. They are information that then allows us to make decisions about where to do an in-depth inspection, stage 2, as Mary has said. The other piece is the thresholds that we compare all of that data against are currently under review, so we just thought we'd let people know that. We've been working as part of the contract with Providigm out of the U.S. On revising and reviewing our thresholds. We actually think we'll have changes in those thresholds over the next couple of months, because they've done all the scientific analysis based on Ontario data. As you know, most of you know, we had to use U.S. data before because we didn't have Ontario information. We now have that Ontario information to be able to inform us. Many of the thresholds we had to trigger the in-depth inspections, we actually actually found were too sensitive in that they were triggering too often and we weren't finding non-compliance. So the data is actually telling us that that is the case. There are a few, though, that will go the other way. So that's something over the next few months that we'll be revising in Ontario. So
great. Thanks, Karen. And you'll note on the last bullet here, we've indicated that the resident interview questions are not considered a satisfaction survey by the ministry. However, what we wanted to do for you today and take advantage of talking to you about this today is to really start making the connection for you. And I know that many of you have already, into continuous quality improvement or your own quality management programs. Because what we're encouraging you to do actually is to use the resident interview questions and perhaps incorporate them into your own satisfaction surveys. Use them. All of the resident questions from Stage 1 RQIs are all available on longtermcarehomes.net. We posted them all, and you can pull them down and take a look at whether or not you can either use the questions as they are or adapt them into your own satisfaction surveys or whatever tools that you're using. So we definitely encourage you to do that. And so that's where we're making a connection from those interview questions into CQI. And also, of course, the other tool that you can use is the suite of 31 inspection protocols, because all of those inspection protocols also are posted on longtermcarehomes.net. They are available to all of you, and as well, you can incorporate those into your quality management programs. And some of the, this is the entire listing of all 31 inspection protocols that are used specifically in their categories within the confines of an RQI, within the context of an RQI, or, of course, inspectors can use any one of these inspection protocols alone or in combination when they are conducting other types of inspections, depending on what the issue is at hand. However, the ones that we would like to point out to you in the far left-hand column, the number 3, which is the family council interview, number 8, which is the residence council interview. Then in the center column, if you look at, for example, something like number 5, which is food quality, or number 8, which is reporting and complaints, those would be really good inspection protocols to really focus on, for example, to get, again, into this whole area of examining the resident and family experience and complementing resident questions and so on with focusing on some of those pieces. And as we said in this previous slide, as well, you can use all of this information, of course, to start conducting your own mock RQIs and so on. So with that, then we'll move over to starting to talk about complaints and the role that they play from our perspective in taking a look at resident and family experience.
So what we've done is we've pulled some data, and as most of you know, we launched the Centralized Intake Assessment and Triage team, who became fully implemented in November of 2012, so it's very new. But in just 2 months, they received alone 389 complaints from residents, families, typically sometimes staff of homes, and that doesn't include, obviously, critical incident reports, which we would have had a lot more than that. But I think that number is telling, because in 2 months there's 389 that came in. And what we're seeing consistently is homes that don't have a good and effective complaint management system in place in their home. Oftentimes it's broken telephone. You know, somebody complains to someone and they let someone else know, but it never goes anywhere. It doesn't get managed well. And as a result of that, they end up getting very upset, and as a result, they come to us. And so these are just some breakdowns there of the types of issues that people are complaining about. But those homes, as I say, with those complaint issues, what happens is you see us a lot more in your homes. We see a lot more non-compliance issues. We often see issues issues from a leadership perspective, and many of those homes are the homes that are struggling. So if there's anything that comes out of the discussion today, is that an effective and strong complaint management system in your home, where there's openness and transparency and as much as possible non-defensiveness, and I know that's really difficult given some of the issues we see today and the difficulties that you guys are all struggling with, and we certainly understand that too. But it is something that I think really helps to, develop better trust and issues within your home. So this next slide is just a context slide just to emphasize the numbers of inspections we've done. It's actually about 6,130 as of January of this year now, 6,130, sorry. But I think the telling piece for us is the percentage that are complaints. So 48% of all the inspections that we're doing provincially are complaint inspections. So 2,881 of them. So, that's driving a lot of the work of our inspection process, and certainly an issue that then results in us being in your homes more often.
And I guess one of the things that we also wanted to say, obviously, is that we don't, from the complaint intake piece, the number of complaints that come in and of themselves, again, they need to get inspected. We need to determine, of course, whether there's non-compliance and issues and so on. So the numbers themselves, again, are not in and of themselves an indicator. There's an indicator of, obviously, people turning to the ministry rather than turning to you to resolve issues. But at the same time, it's, again, not in and of itself an indicator of perhaps directly the level of satisfaction, but the point is that those people are coming to us, and we're in turn out to inspect, and since July the 1st, or just under 3,000 inspections. So those numbers really are actually quite powerful, and I think speak for themselves.
Right. So what does your own complaint analysis, I think, tell you about your long-term care home and your resident family satisfaction levels? What are some of the contributing factors? How robust is your complaint management process? How responsive are your staff and management teams? And what role does complaint management have in your quality management systems and processes? And we've seen this in homes where we've had a lot of complaints coming into us about all kinds of issues related to medication administration, care delivery, different issues. And oftentimes, just the fact that we're getting all those complaints is often symptomatic of other broken systems within that home as well. So I think it is something that all homes can look at. We know we've also got excellent homes out there who are doing a wonderful job in this area. So we also want to commend all those homes as well. And then residence councils and family councils. So we thought we'd take this opportunity just to mention this issue, because the ministry is actually been investing and providing additional funding to the Residence Council Association, as well as working with the family council folks to support them in empowering and enabling the residence councils and family councils across the province. And I know OARC, I don't know if Donna or Dee are here today. Oh, gosh, I didn't even see you guys sitting right there. Look at that. So these guys here are doing a fabulous job of going out across the province, developing tools, supporting their residence councils. And I think for many homes that's an adjustment, because residence councils have not had a large voice in some homes and haven't had a powerful influence. So we just wanted to take the chance to really support them in their work and talk to you about the fact that we see residence councils and family councils as playing a very important role in the life of residents in long-term care homes, that the effective functioning of a residence council and family council can contribute significantly to resident and family perceptions of their experience. We also know it's often, especially with family councils, we do know there's some difficulties out there as well, and I think the more we can all do to support those organizations, I think that's a positive thing. It contributes to empowerment, it contributes to the richness and variety of life of long-term care homes, and also there's education and decision-making that's enabled. So we've seen through the work of these folks here that there's a markedly increased interest by many residence councils in being more involved in the life of the home and understanding their rights. And I just look at the types of issues that we're seeing coming forward. We've got folks today who are coming to long-term care whose families and residents are more informed. And I think that's only going to increase. I mean, I think many of us in this room one day will be very strong in our rights and or for our families' rights. So, as we say, OARC is very active in supporting and educating these residence councils, piloting supports for conducting meetings, etc. And we wanted to just reinforce that the powers of the residence council and the family council come directly from the legislation. They are not given by the administrator in the home. They are not given by a licensee. They are the rights of those residence council folks and family councils given through the legislature to those residence councils. So I think it's really important that whatever we do moving forward, that we support and encourage those folks, because this is their home, and we're certainly supporting the association and the family council program to help give more information and more strength to those organizations. So we just wanted to take this chance to really sort of advocate for the work that these folks are doing, because I think it's excellent work and will really benefit all of us in the long run.
Thank you. Thank you, Mary and Karen. Excellent presentation. We're going to switch it up here again and again, now take you down a slightly different conversation and really more of a personal journey, if you will, where Dana and I will share with you the Revera experience of applying a tool and what it has meant to us and how we got to where we got to, and basically put our laundry out there, if you will, because in some cases we're going to show you our scores and everybody can talk about our performance, which in some cases our worst concerns, isn't it? Which is so misguided, right? Because at the end of the day, I wouldn't say that there would be anybody out there that would think that the voice of the customer wasn't always the first and foremost that we should always have been doing. And that anybody in the world of business or healthcare or any other, marketing company would have said, you mean you're just catching up now and understanding? Look, we got shaking heads here. Are you kidding me? Is this for real? Because in the 21st century, when we've been so concerned about quality indicators and data quality, and we're now starting to understand about the voice of the customer. So it really is an aha for us to really reflect so far, how far are we on that quality journey? So we're going to tell you about our experience. So first off, just a little bit about Revera and where our journey starts. I have to start by really talking about just this year today. Although we've been in the business for 50 years, today, this year, we actually stopped formally and stepped back to look really how are we applying the values that drive forward our organization. We formally stopped this year to mark our commitment to culture change and long-term care. And many of you know those words of culture change mean person-centeredness. And yet, again, being in the business for 50 years, we had to formally mark it and really stop and understand, are we being values-driven? And so here you see the Revera mission, the Revera values. And that really where our conversation formally takes place with the perspective of the resident voice. The values of respect and integrity, compassion, and excellence. It's not much more sophisticated than that. Our being accountable to our values was our organization at every level being driven by the values. And so we did pause formally. These have been our values for some time, but we had to stop. Especially this work we started in long-term care, but as now you're going to hear the story further, is actually transforming the organization as well. So a little bit more about Revera, because that'll help you understand how we actually landed on the tool and the processes that we're currently under. So Revera is a fairly large organization. Some of you will be familiar. Many people don't know about Revera because it's somewhat of a new name, but we have been in the business for 50 years. We have many communities across North America. We have 4 lines of healthcare services: retirement living, home health, long-term care, and in the United States, we do skilled nursing facilities and short-term rehab facilities, as well as some of the home assisted living in the West Coast area. So we have these 4 service lines that we have to bring together. That does represent about 36,000 clients served every day. So when we go about looking at a process change to make something better, we don't think about just one line of business. We'll actually think about the entire enterprise, because we're actually trying to work smarter and not harder and reinvent the wheel. When we started our journey of actually assessing our resident satisfaction and how values-driven were we did look to our 3 other lines of business. Today we're here to talk about long-term care in Ontario, but we did collaborate with our other partners to make sure we actually collectively understood that we needed to be driven by the voice of our company across the enterprise, not just within one line of business. That actually helped us understand how to shape the process of selecting a tool. Because when an organization like Revera goes out to select a tool, there's a very rigorous procurement process, and we go through a lot of evaluations to see what's the best tool for us to deliver the needs and meet our obligations. So in this case, actually, prior to 3 years ago, we actually did resident satisfaction surveys on a tool that we had developed in-house. We standardized. It was very nice. We automated. We created our own IT systems and custom web applications. And we came out with some really great data that was really important to us internally, because nobody else could had said was validated, verified, or actually was true and accurate reflection of a validated tool. So about 3 years ago, that was another aha for us. We needed to start looking at another tool and process that could be validated, externally benchmarked, and used across the 4 lines of business or lines of service. So that was another aha for us. So what's our objectives with you today, now that you know a little bit about our background and this understanding that we're fairly large across North America, driven by our values, and really wanted to hear the voice of the customer? Well, now I want to share with you how we actually do our survey. Dana's going to talk to you a little bit about the methods and the processes, because we actually fundamentally also started the review incorrectly of our new process. Initially, when we went out to survey the voice of the customer, we surveyed the families. To John's point, the family doesn't represent the voice of the customer. We're going to talk to you about how we went through that journey and where we are today. We're also going to show you our outcomes and how we apply that and use the data on a go-forward basis on our quality improvement programs. So just a little bit on our quality improvement module. This is our balanced scorecard. We use this image repeatedly to demonstrate there are 4 equal quadrants to measuring quality at Revera. The 4 quadrants are very familiar to most of us when we look at balanced scorecards. It's what those measures are within those 4 quadrants that might be unique to different organizations or different service lines. Having said that, they all would have that same orange quadrant, the resident, family, patient, client, person voice. You know, that orange quadrant there where you're actually measuring the client's voice of the services experienced. So that's where we started our conversation. What tools or processes were we picking up to measure that voice? The other quadrants are equal in weighting, not greater, not less. And that in itself changes up the quality framework of an organization when you recognize a balanced scorecard approach. The other thing that happened back in 2010 was the release of the Rising Tide report, where Alzheimer's Canada released the Rising Tide report and actually talked about what was happening with the clients that we were serving. The need to have a really good, solid look. Were we going to meet the needs of the clients with dementia going forward as the population changed? We stopped that year again and said, are we organized around the Rising Tide report and the changing population, in particular around the folks with dementia care? After that time, we started to really formalize our person-centeredness model. What did it mean to be person-centered? We needed to translate those words again, being driven by our values, to come up with some actionable items, things that would have to change for not only the employees who serve, but the folks that actually serve the employees, ourselves, as leaders. This particular image or model gives you a visual representation of our person-centeredness now. For some, they say, really, do you need to describe yet again another image? But you do. You need to translate what those words mean so people can follow something, a new way. In this case, this particular model that looks pretty and attractive, the Q and the quality of life, bring some attention to what we're talking about. But it's really that visual circle again in the 4 quadrants that I want to bring your attention to, because we're going to talk about those 4 quadrants and how we use our resident satisfaction survey tool to see whether or not we're being person-centered. Our particular 4 quadrants for being person-centered is that we are evaluating the lived experiences of the elders we serve. The other quadrant is informed choices. How are we offering informed choices so that their lived experience is as they want it to be? How do we measure and monitor that sense of community? And what are those supportive relationships? We use this image of person-centeredness for those that we serve, the residents, their families. We also use it as a way to measure our engagement with our employees on those same 4 quadrants. Person-centered is not just about the residents they serve, but how we serve the staff. I'll just summarize my points before handing it over to Dana to talk a little bit more about the selection of a tool to measure your balanced scorecard, the resident voice, and to measure within that specific areas and domains. As we went about to select an organization that could meet that breadth and scale of tool that we needed, we did have a very robust procurement process where we brought people in, brought together interprofessional members across Canada to evaluate different tools and systems to see who could meet our obligations, who could provide us with the data set, the timeliness of that data set, the data set that's visible at the site, at the regional, at the head office level, that could actually allow us to do some customizations but still have benchmarking. So our procurement process was very rigorous, but an ultimate decision-making process did land on our partners, which is NRC Canada. Dana's going to talk to you a little bit now about that relationship and some of the processes and the tools, and you're going to see those, and we'll then apply that to our quality plan and what our outcomes are to date.
Thanks, Joanne. So we're going into our 3rd year of survey working with NRC Canada. And as Joanne had mentioned, it's been a journey, and we learn each year how we can improve our process. To begin in the 1st year, we looked at some survey options. Particularly, I'm just going to focus on the family right now, and that was a mail-out survey option. Sorry? No. Mail-out survey option, as well as a web option. So we sat with our partners with NRC, and we talked about the tool, getting an understanding of what that tool was about, what questions were validated, and looking at what were some flexibilities that we had in customizing questions for our families. We had some quality improvement projects and activities going on, and this was an opportunity for us to measure the outcomes of those projects. And so they worked with us in order to do so. In determining the mail-out, we used our data set in-house for mailing, and it went to the primary contact. What we did find out is that there were other voices that may not have necessarily been on our server for mailing, and I'm seeing some nods. So in our 2nd year, we took a look at having to improve that so that everyone had a voice. The web option was set up by NRC Picker. Families would receive a cover letter introducing NRC, our partnership, and what we were striving to achieve, and hearing what they had to say about the care and services that they were experiencing in our homes. And there was a link that they could do their web option, and they had a code. So the anonymity was being kept. While that was all going on, there was also a tremendous encouragement for campaigning at the site level. We wanted transparency with our families to let them know that despite us not doing in-house surveys anymore, and we were working with an external provider, we wanted them to know the survey would be coming to them. We were encouraging them to fill it out, and if they had not received it, that we could link them with the appropriate parties at NRC to make sure that they could, in fact, fill out a survey. So the campaigning began with resident and family councils, introducing the survey time period. We also met with our staff. Staff have that touch point with families and residents on a daily basis. So the more that we were all aware and talking about it, we hope to secure a high response rate. NRC then would send out a 2nd wave mailing to the families, and that was 24 days after the first mailing. Our 1st year, we ran into the postal strike. So, and as you know, that was just on or about the end of the spring into the summer, which was another aha moment for us, is that surveying during the high vacation period doesn't necessarily lend to a high response rate. So lessons learned. We also introduced reminders from the facility after that second wave mailing. We know that, the mailing had gone out. Have you received it? Again, troubleshooting if we could. And I would anticipate that this year we'll continue along with that same survey method. For the residents, the first year we did the mail out to the residents. It was a handout methodology. In the second year, we wanted to increase the voice of the residents and reach the residents, as Dr. John Hurdes had mentioned, those that would not necessarily be opening their own mail, completing the survey, and have the means in which to put it back into the postal. So with the support of NRC and our desire, we collaborated on a plan in which 3 sites were piloted for facilitated interviews. NRC went into 3 of our homes in the GTA area, and they facilitated interviews one-to-one as well as a large group. And from there, we were able to complement that process throughout our other homes through a train-the-trainer method. And we used, for the anonymity piece, we had people from other homes go into another sister facility. And basically, there is a science to it. So through the trainer, our staff went through how to actually facilitate an interview so that it would be as a validated response as it's required. The actual facilitation of the interviews, the residents, we used the MDS tool to determine their needs and how we could then, in fact, meet their needs for the completion of the tool. Who would be more comfortable in maybe that roundtable facilitated interview, and those who would probably be more best set for a one-to-one. So these next 2 slides just give you a visual of what the actual survey tool looks like. This is the family survey tool, and you'll see that, I don't know if you can see it well, but there's living environment and communication with staff. Joanne had mentioned that there's like subcategories or domains, so that when we look at getting our results and our reports, we can understand the categories in which those questions roll up into aggregate outcomes. And there are some, you'll see it is also like a Likert scale, so it's not a yes-no, it is a graded scale. And there are some questions that, as you can see, that they would enter an answer. You can see on the bottom of this tool there's an identifier. So that's where the anonymity comes in. Families there's no names. However, if there happened to be anything that would have been an alert or a concern, NRC Picker, of course, would be able to link us with that family if they felt that it was needed. The resident survey, because it's a different perspective, although it may have a living environment and the same domain, the questions are a wee bit different, and there may be even a different number of questions because their experience and their perspectives are much different. And as Joanne will talk about our outcomes a little bit, we did learn that there is definitely a different thought in their experiences when it comes to dining and food and whatnot. And that takes me to the end of that.
Just another point about the questions. So they are standard questions where we do benchmark internally and externally with those series of questions. Just to highlight another piece, we do have the opportunity to put in 5 custom questions, and we do so to be able to really measure some specific quality improvement initiatives, very focused areas that was a system-wide improvement across the organization. So if we really did know that we needed to address a matter, we could put it into the tool and pick up the voice of the customer on those 5 custom questions, which nobody else really is interested in, but we're very interested in because we maybe committed a lot of time, money, and resources to see if we can address a specific need for an elder across the enterprise. This pictorial is coming right off the tool right now. It's one of the ways we actually get the data back. This is an aggregate correlational analysis that shows us our priority matrix. Where does the organization at the corporate level now need to focus their time and attention? Because there's so many things organizations will try to focus on. It's hard to kind of focus it and drill down. It's a little bit difficult for you folks to read here. We've highlighted in the actual quadrants, key areas that we had to focus on as an organization to get better. A site would not see the priority matrix for the corporation. They would see it for their site. So they'd be able to drill in very specifically how their actions needed to dovetail to the needs of the residents they served locally. It's very important, though, again, to have both a local voice and a system voice when you're working across an organization. I mentioned to you already then the access of the data, that you have access as an executive director and a management team. You go onto a web portal, you're going to drill in and go into your response rates and all your responses and be able to access that information on a regular, ongoing basis and create graphs and images for your staff, frontline folk, residents council, family council to see. However, across organizations, when you actually work in regions and try to group people together, we have that regional access as well, because we do organize our work around the regional model. We need to have this tool to be able to evaluate against the regions. And then finally, we do have the corporate roll-up access to have aggregate data reporting as well. This is all done on the portals, so people have access 24/7. I believe as well, we haven't used it, but NRC Picker does do work obviously in U.S. with My Interview. That's the other name of the U.S. company division. And they'll have a dashboard, corporate dashboards that can be seen on a regular ongoing basis. We initially did survey on an ongoing basis after move-in or admission and annually thereafter. We moved to a static once-a-year survey when we moved to the new process. And the reason initially to do that was to actually get that response rate up. We felt that we could do a really strong campaign, get strong voice of the customer, really focus in, because that was really important for us. Now that our processes have really tightened, and we did over 6,000 respondents last year to our survey tool, so we've got a really strong voice of the customer now, we might consider some more frequent roll-in data points, because you do miss a little bit of the data if you don't get it on more than an annual basis. Some people want to see it on a more regular basis. We haven't made that consideration fully to change back, but it is an option for us. Here you can see now a report that a site might be having at a local level, where they're actually getting a roll-up report on a particular question. This one actually is a family. It gives a corporate response, and it's actually giving 3 bars across each one of the grids to compare how are we doing in the previous years, how are we doing in the current year, and how are we doing in a benchmark. Below on the table below, you'll see that we actually get the sub-questions under those domains, where we can actually check our response on some specific questions that roll up to the overall score. This particular question is look at the overall ratings for the family, and it is, we can't quite see here, can we, guys? I can't see. Overall quality, I'm not seeing it, Dana, though. Okay. So this is a visual image of what the sites would see, and they can actually pick up those scores locally and action plan accordingly. And we can also show that we can action plan at a corporate level for the same areas of domains if it's a corporate issue.
Sorry. One of the interesting pieces with the action plan reports is that often when we do our surveys, we used to think that the lowest score was the one where we should pay a lot of time and attention to, and that was the one that was of great significance. We get a correlation analysis through this, so those 3 bars on the bottom are also telling us which domains are really of significance and are really meaningful to the resident and or the family, and that really allows for some really rich quality improvement conversations, and project teams can utilize this information.
So let's actually just go back here again now to the quality improvement model that we have for person-centered care. We'll remind you that we're actually taking a look at those 4 quadrants and how the actual survey tool informs us and evaluates us against some of these areas that we're focusing on. If we take a look at the area of lived experiences or informed choices, we pull up into our survey tool and we see now again an example of the resident's voice on dignity, which for us is one of the measures we'd be watching at to see whether or not we're being person-centered. In this case, again, now you can see a better visual representation of the actual area of dignity. You can see the current period, we scored 79.0%. The Canadian long-term care average is 79.4%, and a high-performing average is 93.7%. So an aspirational target for us would be to grow from the 79 or 79.4 to achieve a 93.7 score. Below, you can actually see our performance here in the area of those subdomains, how to treat it how you want it to be treated. That's the resident perspective, 66.1% of the time. Previous year performance, 75. A top performance score was 97.6, and it's dropped this year to the 93.7 you can see above. Not ignored by staff. Physical or personal physical privacy respected. And you can see the arrows here on the columns if you're going up or down trending over the previous years. The top 3 bars, the green ones, are the ones that are really the driver of the overall. So those are the ones, if we're looking to focus on anything, if you make your efforts and focus on those areas, you're going to improve that overall domain of dignity. to me and to us as a team, this is an example of measuring our culture change. If we actually select a performance measure saying, I'm going to actually really work on treating how you want to be treated as a performance measure on culture change, we would continue and we'll resurvey the following years to come and see if we're moving that indicator by our key strategic initiatives of activities that the sites may come up with, that we may come up at a region or a corporate level. So in summary, what we had to do as an organization when we took a look at needing a tool to evaluate the lived experiences, the resident experiences, was one tool that could be used and applied across the 4 lines of care and services. We needed to be able to benchmark internally at the regional, at the site and the regional, at the corporate level. We also needed to benchmark across the organization. These scores do go up in a roll-up scores onto our balanced scorecards that go to the quality committee as well as the board of directors. And we really needed an application that could be supported back at the house and access into those web portals with some systematic approach versus having many different IT, passwords and logins and sort of things that makes it difficult for us to manage as an organization. And finally, we needed to strengthen the integration of the data. So having one provider moving information into the company, working with a team of people that are part of our resident family engagement survey hub, allows us to actually strengthen the process all the time and really get that provider of service understand the unique needs of Revera so that they can fine-tune their work. What we found from the beginning, it was hard to get one perfect tool from the beginning and end and that you just, plug and play, so to speak. But now over the course, this will be our 3rd survey year this year, and the process of improvement that we put into our commitment to making sure we hear the voice of the customer, we're sure that the total end size this year will not only go beyond the 6,000, but that we'll actually take it up to a level where our voice of the customers truly will be driving the organization and hold us to our core values. So thank you very much. That's our application of a resident satisfaction survey process. So at this time, we actually have time for questions and reflections on the material. You've heard really from Dr. John Hurdy's, the quality of life tool that utilizes some of the familiar processes and language that we're familiar with at MDS RI, but the quality of life tool that he's building. You've heard from Karen and Mary around the resident satisfaction and the process of RQI and the tools and information, the complaints management, and an application of that from Dana and I. Are there questions that are top of mind, reflections that you may want to ask the group? We do have a microphone here. If you could please come to the microphone that's just behind you. You can just shout, then go for it. As an organization, we make our results public at the site level, so they're posting their local outcomes. Our aggregate reporting, we haven't done that yet. That is a vision for us to, get a web portal up so we could share. We certainly also produce our results in our annual reports. So we do have a hard copy annual report that does go out about key areas. It's not all pieces, but we might highlight areas that we've been focusing on. So in that regard, we do as well make our results. But we don't have them on the website just yet as a quality portal, but that's a bit of a vision for us as well. Yes.
Can you tell me from the time that a family or a resident would complete the survey, how long does it take in our sticker to get that information to you?
Because we're doing that annualized survey cycle right now, the return rate could be, within the window of a week to 2 weeks to NRC picker, right? Once we're in the survey phase, which we usually start in May to June, and we really do strong campaigning because we want a lot of surveys back, we get a weekly response rate to see how many counts are coming back to us. So we'll be checking to see that. So I'm not sure if that answers your question, but that's kind of what happens. And if we don't see those counts getting to a good response rate from the resident or family, Dana will start different campaigning processes, and we might extend the campaign because to us it's all about getting, that response rate up very high. I'll take the mic and then up. Yeah. Hi, Marg.
Hi. Thanks for a really informative dialogue from all of you. It was very interesting. My question really is, I guess, to Mary and Karen, that Proviadigm actually has rejigged their survey tool, and I recognize it wasn't initially as a satisfaction tool, but they have now rejigged it into quality of life domains as well with some other key questions. We still don't have the liberty to craft our own questions into it. Any thoughts on that and where we're going, if there's a provincial drive for one satisfaction tool across all, or is the fact that we're just even asking those questions of our clients and our residents a good starting point?
Rob, are you in the audience? Yeah, you are. Do you want to take this one? Because you have the lead for this, right? Sure. So Rob Francis, one of my colleagues with the Ministry of Health, works with Susan Petkow's area, and they've sort of been looking at the whole issue of resident family satisfaction, and I don't think we have a conclusive answer, but I'll let you.
No, but thank you for asking. So I think there's lots of opinion out there that there's value in standardized satisfaction surveys. I think most reasonable people would agree with that. It was recommended as early, I'm sure before, but Ms. Sharkey addressed it in her Staffing and Care Standards report. I think it was identified in the Task Force on Abuse report, the value of introducing a standardized assessment, standardized satisfaction tool. The ministry's done some preliminary work on what would be involved with that, but I can't say that there's been a public commitment to getting it done by a specific date. As I said, I think there's lots of value in it. I think there's also challenges. We heard today from Rivera that they've gone one route with it, and it sounds like it's a pretty impressive tool that they've implemented. But I assume that other providers have gone other routes. So I think it's worth looking into, but I don't know that there's a set plan to introduce a standardized survey anytime soon.
Okay, thanks, Rob. So maybe just to add, I think to reinforce what Rob's saying, I know talking to many homes are doing resident family satisfaction surveys. I mean, we know it's a requirement of the legislation. So many organizations, just like yourselves, have already gone out and done that. Some homes have actually they've picked up questionnaires and then they've added questions from the RQI questions. So there's many different approaches that people are taking. Maybe there's some benefit at some point in time. You have the option to add 5 questions. Maybe if nothing else, we could, as a system, decide that there are 5 questions we'll all include in the satisfaction surveys that you do. I don't know. But I know that, John, you're working with a number of homes in the province as well. Briere is also looking at it as part of their CLRI work. So I don't think there's a definite direction because lots of people have already moved forward and developed tools. So,
just to make a comment before we take your question, Mary. One of the things that the OLTCA, the Quality Committee, has done is tried to understand with all the various tools, is there a couple questions that are common under the different tools. So an example for one common question, and we didn't show you our results, but from a family's perspective, a common question for us is, I would recommend. And we saw that common question on all kinds of tools. So that would be one that was transferable regardless of who's your provider. So we would have that question. We didn't show you that. Overall questions, are you satisfied, from the resident's voice? Those overall domain questions, again, a common one, are you asking that one? So regardless of who the provider is, if we can land on some common questions, might be a way that we can navigate all the variabilities. So
the challenge with going the route of the common question, though, is that it might be a problem of the lowest common denominator. And actually that item on would you recommend this home to others, we have it in the Inter-I survey, and it's not a particularly good item. It's one of those that you tend to say yes to because it's a nice thing to say. It doesn't differentiate quality all that well. And so some of these things that we think, you got to have this question on it, it turns out the question's not all that useful compared to ones that drive more variance between populations.
Excellent point. Excellent point, John. Mary.
Hi, thank you. Mary Schultz from the Alzheimer's Society of Canada. Very interesting panel. I thank all of you. And I'm certainly no expert, but from what I'm reading, I seem to have heard this echoed again today, families will define quality of life and will identify satisfying indicators differently than residents. So there's quite a dichotomy. I'm wondering if any of you can comment, or if you've had an opportunity to think about, how do we bring those two viewpoints together? And are there any strategies that this research is indicating would be helpful to help families understand that quality and satisfaction in the experience is defined differently by the resident, and that we really need to listen to that perhaps even more than the family's experience, I'll dare to say. So are there any strategies to kind of help bridge those different perspectives, or is it too early?
Well, I think one of the things to be careful about is trying to force a unified answer. Sometimes what we try to do is sort of look for simplicity by coming up with one number for an overall quality score or one rating on a subjective rating, because we don't like complexity. But particularly for persons with dementia, we got to live with complexity. So if we look at people with a CPS score of 0 to 3, we can generally get them to respond to self-rated surveys of whatever type. With people with a CPS of 4, it's difficult. You're lucky if you get about a 50% response rate. Beyond that, anybody who's telling you that they're responding reliably to a standardized survey, they're pulling your leg. There's not science to back that up, and so let's not kid ourselves that we can somehow get very high-quality standardized data for people who are severely cognitively impaired. So what do we do then? My answer is don't take the family ratings and say, well, that's what they would have said. But just treat it as a different perspective. We got some missing information here from the resident's perspective. We do have some information from the family's perspective. We also have the clinical information from the objective assessment that tells us about quality of life. There's lots of stuff on pain, on social isolation. That's another point of information. And then we use other approaches to try to get some information, engaging resident councils in more open-ended discussions, doing some more qualitative surveys with those folks, and just appreciating the limits of our evidence. Where we don't have evidence, the responsible thing to do is make our best judgment that we can with other sources of information, but not kid ourselves with fake evidence in there that we somehow transported from somewhere else. So unfortunately, it stays complicated.
Thank you, John. Yes, another question.
Yeah, absolutely. I mean, what we're doing now is we're looking for homes to work with to start to use our surveys, that we want to start to do this on a benchmarking basis. Initially we did some research projects, but now we're actively recruiting homes to work with us, and we're happy to sort of talk about how we might do that and start to do the benchmarking. And we've got one of our colleagues from the Schlegel Homes in the back, so would you like to comment?
Yeah, if anyone's interested, the project that I head up across our organization, I'm happy to share with you how we've been able to implement the tool successfully across our organization. All 11 of our villages, including retirement and long-term care, are using this tool now, and I'm so pleased to say that we are making business decisions based on what we're seeing in these 10 domains, and it's just phenomenal to see the results thanks to the assistance of Dr. Green.
Yeah, and one of the things is that this is an area of INTROI research that's sort of a funny one. We found that there's about 20 members of INTROI who've done this research for a long time. I did my area of specialization during my PhD in quality of life measurement. I was trained originally as a survey researcher, and so this is what I grew up doing. And then, I began to be involved more on the assessment side of things, but this sort of is coming back home for me and doing research. And we found that in many people in the INTROI group. So we're newer to the space as an organization, but we've got a lot of depth and expertise in this area, and we're very interested in pushing this as international as we can. I think one of the strengths that INTROI adds to the mix is that we do have this international perspective. So if we have a multicultural society, one must think about the impact of culture, and so we've got to be careful about questions that are double negatives or confusing to native English speakers. They're a nightmare for people who are not native English speakers. There are cultural issues with, if you use the strongly agree to strongly disagree framework, that doesn't work so well, because in some cultures you're not allowed to have strong perspectives. So we've done a lot of work to try to take that into account as part of an international group, so we think we've got some better answers in that regard as well. But our aim is to expand in all those countries I've shown you to be able to do the benchmarking across Canada and internationally.
Another question or comment?
Thank you. I'm Donna Fairley from OARC, and I have a question for John and probably for you as well, and it's to do with the resident. When you went out and you asked residents their opinion and you got their answers from residents. I wanted to know if you collected any data on how many residents actually answered those questions independently, or how many residents actually had assistance with answering those questions.
Well, the approach that we used during Vahi's dissertation, and maybe you should speak to the training you used, was an interviewer-based approach, and I think I think that's also the case for all the Schlegel homes, but perhaps you can comment on that. Generally, what we're seeing is that we do see an interviewer assistance with it. In our mental health instruments, it's 50-50 in terms of interviewer-based versus self-reported. So what did, you guys are doing interviewer-based as well, right?
Yeah, 100% interview-based. So they're done by individuals who don't provide direct care for that resident. So where possible, those in retirement are interviewing or surveying in long-term care and vice versa. We haven't had the need as yet to actually cross our homes, but have been able to find enough surveyors or interviewers to provide them for interviews. So, and the only place that we've run into some concerns or issues or questions around that are with couples. So spouses tend to want to be interviewed together, and it's a place where we really had to draw the line in the sand and say, I'm sorry, but this is something that's done on an individual basis. Each of you will have an opportunity to provide information, but that tends to be the only place where people want to be together. But we have gone to resident councils and family councils before we implemented all of this to address what it was that was coming and why it was we were doing it, and shared all of the questions with them, and took some of the scariness, I think, away from what kinds of things we were asking for and what we were going to do with the data.
Thanks. I mentioned that because I've had a president of a resident council who's, for a couple of years, have said to me, I don't like these corporate surveys. They don't speak to what is relevant to us. And they have a new administrator at their home, and this new administrator said, go ahead, go for it. The resident council designed their own survey, and they also chose who they wanted to be doing the interviews, because they also had issues about who the home was sending in to do the interviews with the residents. So just food for thought.
Excellent reflections, and we actually had some similar feedback and had conversations at Rivera of how we can do both, because we do need to be very mindful of having information that can be, kind of validated into a stream of information to be able to do organizational performance. Having said that, the most important piece is the voice of the customer, making sure they're heard. Not many people have brought that forward, but there are a couple. Right. So it's more of a one-off. So we do need to make sure we listen to what their interests and their needs are. So I welcome that feedback. We've heard a little bit of that ourselves. Also how to do what we call pulse surveys. So you may be doing something like this on a big system level, but on a site level or a smaller level, pulse surveys is another process that we put into place, because we may want to look at something very personal that's very different and very much away from a corporate perspective. Right. So we definitely do the balance of both, and I think that was probably always the case and need to be.
Right.
Yeah, great point.
This home even went one step further and allowed 2 of the residents on the leadership team of their council to participate in the training.
That's fantastic. I think at this point I'm going to have to hold further questions, because we are coming to the point of close, and we do have sessions that are going to be wrapping for the end of the day. Truly an engaging conversation with a powerful panel of leaders that have expertise and insights into something that's important to all of us, and more importantly, that it's our obligation to make sure we hear and serve the residents that we care for every day. Thank you for your attendance.